I
Go
want to
ahead.
know, are there any homework for us for last week, last Friday?
No, there is no homework. There is exam at the end of each module. That is it.
You will put the homework online, right?
Right, correct. The
Okay.
exams, it will be sent to you at the end of each module. So yeah, you will
Okay,
know.
thank you.
You will know. There is no homeworks during the module, no homeworks.
Okay, thank you so much.
No problem, sleep. Okay, so let's continue with this medical records management. We're gonna do a little recap, particularly the things that I want you to remember with this classification of files or medical records. So it's very important that you understand that these medical records are classified as active, inactive, and closed. This is important because if you understand this, you're going to be able to answer questions and most importantly, to make sure that when your patient comes to your office, you know exactly who you're dealing with. Remember, new patients, totally different. Active patients are different from inactive and close. So again, active patients, very easy, are all those patients we are currently seeing with at least 1 year. So some of the patients, if they don't have medical conditions, they will come back to the office every year for a physical exam, complete physical exam. Or whenever they have any issue, they will come to the office. So you don't have to have these patients all the time. If they don't have medical conditions, what I'm going to go to the medical doctor for. But yet, every single year, at least you have to show up to your office. Now, that will be considered active files or charts or medical records for these patients that are currently coming into our office. Some of the patients are visit our office more frequent than others, but again, it's because probably they have some medical conditions, they need some medication refill, or any other issues that might be present at the time of the visit. Inactive patients, remember, these are the patients who has stopped coming to our office for a period of 2, but less than 3 years. So again, these patients, you might ask them, because you always have to ask them, particularly you that you're going to be new, you don't know the patients, and we're not going to recall all the patients. A patient who has stopped coming to our office for 2 or less than 3 years, probably we're gonna forget who this person is. Maybe we're gonna remember bad face, but we have so many patients that we can actually um kind of reassure that this patient is being now only for a year or less than 2 years. So we confirmed with the patient, when was the last time that you were here? Always check. If you have paper-based medical records, you're gonna look on the files, whether on the cabinets or this open shelving on the wall, and look for the chart. If you don't find it, chances are that this patient is being seen longer than that. So have not been seen longer than that, what the patient is telling you. So that is going to teach you that you shouldn't be wasting time looking for a medical record that probably is not even on the shelves or the cabinets as an active patient. So you got to confirm that so you don't waste time doing that. Close files, remember, these are the patients that have stopped coming to our office. The last visit that they have in our office was 3 years ago and after. So these medical records are not there. These closed files, if a patient shows up 3 years later, remember, we are not going to use the medical record. Number one, because we don't have it there available. But if we do, check the last visit, check the last time that the patient was seen. And then you make your calculations. Oh, this patient hasn't been here for over 3 years, 4 years, 5 years. This medical record, we cannot use it anymore. We cannot continue writing down information on this medical record. By law, this medical record is already closed, regardless whether these medical records is within the active files. It doesn't matter, but we have to see the last time that the patient was seen. Because remember, we cannot add information. We're going to create a new chart, a new medical records, a new file. So we're going to start from scratch. But the old chapter, if we have there the inactive or the closed files, in this case, we're going to put it together with the other chart, with the new one, because we need a reference about what we did or what the patient has in the past before stop coming to our office. So again, that's how it's done. So don't forget that, because that's very important. If we start writing down on these medical records, if something happened to the patient, the office is going to be sued, and all that period that the patient was not seen is going to be considered as abandonment. For that reason, we are going to be in trouble. So don't do it. Many things probably have happened during the time that we have not seen this patient. Anything can happen to these patients. Might be sick, might have something else. So we're going to be responsible for that if we start adding information to the medical record after all this period of absence. So we don't do it. Now, if the patient has died, there is no reasons for us to be worried. Patient is not going to come back to the office. The patient has moved somewhere else. Probably they're going to contact us to send the files to the new doctor, to the new medical provider. Other than that, we're not worried about that. But we need to know the difference between the classification of these medical records. Okay, moving on. Let's talk about retention, because this is the part that we left off last Thursday. So retention, we are going to decide which files we're going to keep and for which period of time. So we have to get to know the policies of our organization, because those policies needs to be followed through. So there are certain files that we need to keep for 2 years, for 3 years, for 5 years, 7 years, 10 years. Some we might have to keep them indefinitely. So again, we need to follow the policies of our organization. Always remember, we do not set up the time in the schedule for retention. These are by certain offices, certain regulations, and who is the physician? Whoever is in charge of that practice or that hospital, they're gonna set up those times for getting rid of materials that have already passed the limitation in which we're supposed to be keeping them. So that's basically what it is. So which organizations determines the period of time that we should keep medical records or information contained within the medical records or the medical chart? Well, we might have some documents that might not even be pertaining to the medical provider. Remember the immunizations? Immunizations, we need to keep it for a certain period of time. The employees' health records. Remember, if you work in a hospital, usually is when we create a medical records. I did have a medical records when I was at the hospital. I was working as a medical assistant at the beginning. Then I have a medical records as a medical doctor. So you are going to have one. Now, if anything happens, remember within your premises, your institution, medical related, they're going to be taking care of you because you work over there, because probably what you develop or you have, or the condition that you have acquired, it is related to your workplace. So we have to have a medical records over there. Doctor's offices usually have medical records from you. That's not how it is set up. This is for large organizations. Again, medical office financial records, those are other type of records. This has nothing to do direct. Yes, with the payments that we receive from patients, discrepancy or any issue related to reimbursement from insurance companies, or check these whether there was fraud through insurance companies based on, filing of claims done wrongly. That's basically what it is. So again, that's mostly what we need to understand, because they might be also, the IRS might come after your financials. You are not declaring every penny that comes to the office. In other words, you're not paying taxes on this money that you're receiving. Again, might be the American Medical Association now, or the American Hospital Association, the AMA. Remember, this is the organization that deals with licensing to medical providers. It's not the AAMA, which is the American Medical Assistance Association, which is different. So again, these organizations have to do something with the medical records. HIPAA, of course, the Health Insurance Portability and Accountability Act or law, has to do with patients' data, privacy, confidentiality, and security. So they are involved if something happens, some release of the patient's information has been done without the patient's proper authorization. Any other federal and state laws that has to do with, keeping all these medical records private, confidential, and secure, or any other dealings that we have to do with the operations of the organization, it will be under scrutiny if something happens. So they are keeping an eye on every single organization based on the patient's care and financials. So that's important. Remember, we talk about fraud a lot, so this happens, and it happens more often than not. So again, they are keeping an eye on that. Last part that we talk about the transfer of records. Okay, so how to move these records from active to inactive and close. We discussed that already. We have some policies in our offices how to do that. I told you already the timeline in which these medical records are moving from active to inactive and close. Now, one of the terms that I want you to know is what is the term that we use when we kind of classify these medical records from active to inactive to close. That process is called purging. Remember, we're going to purge these medical records, meaning we're going to separate the ones that has already met the criteria to be considered inactive or closed. Then we're going to see the statute of limitation. Remember, this purging is not the same as statute of limitation, meaning for how long are supposed to be keeping information within the medical records or the entire medical records per se. So again, very important that we understand and we do not mix up information, because some of the terms sounds like the same, but they are not. They have little differences. So sometimes we might use them interchangeably, but some of the times we cannot do that, because it's going to create little discrepancies just using one term and then um, using it for another process that is different or has sorry, or has some differences. So purging means just the process of separating, transferring those medical records from active to inactive and then close. When the medical records are closed, meaning after 3 years of this patient not being seen by the medical provider for any other reasons, whether the patient died, the patient moved away, the patient just didn't return to the office, found someone else, not a problem. We go by the timing. We don't use where the patient is at. It's by the timing. You have not shown up to my office for less than 3 years. We're going to move them to the inactive files. We leave it there. And after 3 years of this inactive charts being there, so not 3 years, but after these charts that were removed because the patient after 2 years, 3 years didn't show up, then it's going to become closed. Now is how we are going to determine, depends on your state regulations about time, the statute of limitation. Now we're going to decide when are we going to get rid of these medical records, not to place it safe somewhere else. No, we're going to get rid of it. We're going to discard it. We're going to destroy these medical records. So that's basically what we need to know. So that will be retention and destruction. That's a different issue. So purging is one thing. Now the retention period and the destruction period. When are these medical records? Are we supposed to be destroying them, removing them? We don't need them. If a patient has already has not come to our office for 7 years, 10 years, we need to get rid of these medical records. Now, that statute of limitation have changed now, because now we have electronic medical records. Remember, these paper-based medical records occupies lots of space, and purging all these medical records from active to inactive and then to close, it takes a lot of work, a lot of space and money, because sometimes we have to transfer this to another location, pay rent for a place when we can keep these medical records safe until the time that we need to destroy them. So again, it causes a very big hurdle in this situation. For that reason, we need to get rid of them. So most of the physician keeps medical records for 7 to 10 years minimum. This is a question for exam. Remember, I'm going to ask, so the national exam is going to ask you. They're going to ask you, what is that called the statute of limitation? So they're going to ask you, okay, what is the statute of limitation for medical records? Well, that varies from state to state, but mostly standardized, most of the laws in every single state is 7 to 10 years. Particularly New York is 7 to 10 years. So you're gonna see the answers over there. Oh, you're gonna save it for 1 year. No, that's false. Because remember, after 3 years, it's closed. So 3 years, that's when you close the medical record. So you cannot destroy it right there. You gotta wait until it meets the criteria for the state law. Then it's gonna be 7 to 10 years. Now you're gonna be seeing that answer, 7 years or 7 to 10 years. So that's the one that you're gonna select. You're gonna say 5 years, 3 years, 20 years. Now, if it is electronic medical records, which we are going to be talking about after we finish with these first 2 chapters, that it is based mostly on paper-based medical records, now we're going to have a little different criteria. Why? Because if they are in electronic form, now we probably can save it forever. Because doesn't occupy much space. It's going to be in the cloud. It's going to be in a electronic magnetic storage, and they don't get damaged. Versus paper. Paper, after a certain time, is going to get damaged by itself. It self-destroys themselves. It gets folded, it gets wrinkled, it gets broken, tear off, so many things that can happen. So remember, 7 to 10 years will be the statute of limitation for medical records based on paper-based medical records. But they're not going to ask you, okay, if it is electronic, for how long you're going to keep them? Usually not. They give you questions about paper. For that reason, we go over this. It says right there, some records may be warrant longer retention periods. Of course, if there is something that is under investigation, those are the cases. Nobody's going to ask you this, but an answer to this particular statement is that if a patient is if the case of the patient is under investigation, then it is litigation or some type of fraud, we cannot get rid of those, even though if met the statute of limitation. Let's say that it is a minor. See, a minor, the medical records for minors works a little bit different. Why? Because we have to keep the medical records until the patient reaches the age of 18, which is the majority of age, and then 7 to 10 years after. So if the child passes away like at age 7, 8, 9, 10, 11, 12, 14, 15 years old, before 18, we have to keep them until they reach the age of 18, even though if they have passed away, and then 7 to 10 years after. Those are the law, those are the regulations. So that's basically what it is. It says right here, records for minors, for minor patients, of course, should be kept for at least 7 to 10 years after they reach the legal age. So this is not like, oh, the child died when he was 7, so we're going to keep it 7, 10 years old, so 17 or 14 years old. No, medical record is going to be kept after the patient reaches their majority of age, which is 18, 7 plus 10 years after. So this is very important. Now, remember that each medical record has not only a number, but it has a date when the patient was for the first time registered. So that was the year. So we have these tabs right there on top of, to the side of the medical records. So we organize that by those dates. That's how we know. We check, oh, patient was for the first time join our practice 91. It says 91. Then the month, then the date. So we're gonna arrange them based on date that they join our practice, regardless of what it is. If it is a medical doctor's office or it was a hospital. It doesn't matter, but it's going to follow the same requirements, the same protocols. So remember, retention or statute or limitation for medical records is 7 to 10 years. For adults, for minors, 7 to 10 years after they reach the majority of age. Don't forget that because it sometimes sounds a little tricky, and you might think that every single medical record should be following the statute of limitation after the last day that they were seen, not for minors. It changes a little bit. Okay. We always have to follow, remember, it says follow local, state, and federal guidelines for retention and destruction of medical records. Always we have to follow this. So what's local? Local means your institution. What is your institution wants to do? Now, your institution has to follow the state and federal guidelines. What I'm trying to tell you here is where are they gonna put these medical records? How are they gonna destroy these medical records when the time arrives? So follow local means the institution itself, but it is how it is being destroyed, not for how long you need to be it needs to be retained, because according to the state and federal laws, our offices here in New York, you have to retain it regardless of what office we are working with patients, whether it's a medical doctor's office, large, small, or a hospital, we have to keep the medical records for 7 to 10 years. But the way that they destroy varies a little bit because depends who company they hire. So again, in most cases, keep medical records at least as long as the length of time of the statute of limitation. Now, here is the term, because when you're going to see this in your questions, they're going to be talking about statute of limitation. Statute of limitation. O sea, what is the statute of limitation for medical records to be retained in New York State? 7 to 10 years. Well, other states have different laws, but when it comes to exams, you're not going to be based on every single state. How do you know? The exam is made of for everybody. It's the same exam, whether you take it in Florida, you take it in North Carolina, maybe you take it in California, New Mexico, you name it. It's the same exam because it's a national exam. And each one is not going to be customized just for this state because it's not a state test. That's the difference, because the state test, then it will be based on rules and regulations of the state. Here it says local, state, and federal, because federal is national government, a level or a national level. So you're not going to have something that's, oh, well, Professor Hoyer said 7 to 10 years. And what if I want to put 5 years? Well, it will be a wrong answer. But I was living in California and over there was 5 years. Well, I'm so sorry for you. It doesn't apply because they are not asking you specifically in California. They are asking you in general. What is the statute of limitation for retention of medical records? So remember, it's not about what we've been doing before or in my prior job, it's what the laws at federal, state level, we have to follow those. So again, it's not for confusion, because I know that when we see those questions, we get a little thrown away. Oh, well, wait a minute, it says right here, but I read also, no, as a general rule, just pick 7 or 7 to 10 years, according to the statute of limitation. Now, if they ask you a question, okay, so what is the statute of limitation for retention of medical records or retention and destruction? Then you don't see years over there, 7 to 10, 5. They're going to say, oh, it's based on state and federal guidelines or regulations. Oh, that's the answer that you're going to pick. That's a different issue because it says right here, because we have to follow local, state, and federal guidelines. State, just the state regulates certain things. Remember, we have a country, then each state has their own regulations. So if we move to another state, we might have to do things differently because the laws are different. Even though some of the laws might be the same, the statute of limitation might vary in between those. So that's basically what it is. Any questions about retention and destruction of medical records? So how are we going to go about destroying these medical records? Well, remember, this is not something like the image that you see in there. Oh, we're gonna shred them. We're gonna throw them in the garbage. No, negative. That's not how it's done actually. It says right there, maintain confidentiality. Well, that's why we hire a company. There is a company that it is authorized by HIPAA. It has to be a company that is authorized by HIPAA to do exactly this, destroy these medical records. Now, these companies are responsible for every single medical record that we are giving to them. So, and they have to destroy them. They cannot just keep them or sell it or publish it. That is illegal. That's why we hire a company that it is legally authorized to do this. So when we said maintain confidentiality, is because they know, because they are accredited, they are authorized by HIPAA, so they have to pass this accreditation process. And we contact them, and then they're going to come over and they're going to pick up all these medical records because there are personal information there that is called personal protected information. So we need to protect the person. So remember the name, the last name, well, full name, date of birth, address, telephone numbers, emails, insurance IDs, names of the family that shows over there. It's not about diagnosis, it's about the patient's information, patient's protected information. That's what we worry about it. So that's basically what we need to follow. This is not our job as a medical assistant. This is the job of the office supervisor, the doctor. They are the one who contact these companies after 7 to 10 years that they decide to get rid of these medical records. They pay them, they bring a paper, they sign. Every single medical record that is going to be destroyed needs to be recorded in a form. It is documented, and we keep a copy, and we give a copy to the company who is going to destroy them. And they have to sign it because this is very serious in order to maintain confidentiality. Now it says right there to shred this. Well, that might be part of it, but it's not the complete process. It might be not a shredder, it's a pulverizer. So they're gonna have a machine that pulverizes. They put all these files and they're gonna make them powder. That's basically what it is. Because when you shred papers, you can put them together, you still can read the information of the patient. We don't want that. Remember, that will be violation of HIPAA. And for each violation, there is a 1 to 2 years detention jail time and $200,000 per each medical record. Who's going to pay that? That is very serious. So these medical records needs to be pulverized, needs to be incinerated. And when that happens, these people who are doing this job, the company that we hired to destroy these medical records, they have to bring us a copy, a certificate, it's called, that they have destroyed every single record that we gave them. So that's basically what it is. So let's say that later on, somebody came out and is suing the hospital, the clinic, because the information of one of the patients was revealed. Well, we're going to go after these people because we gave them these medical records and they have to keep these medical records confidential. That's why we hired a company that it is authorized by HIPAA. So we assume that they will do exactly that. We do not destroy medical records. We do not burn them. We do not shred them. We will not pulp. We don't have this equipment to do that. And much less, we are not going to throw these medical records in the garbage. So that is violation of HIPAA. So that's basically what it is. I already mentioned that every single record that we are destroying or we are sending for destruction, a list of all those documents needs to be kept in the office. So we are destroying 100 medical records. Each medical records, we're going to have a list of who we actually destroy because this is our office. We can keep a list of the names of the medical records that were destroyed with all the information about when the medical record was created, when was the last time that the patient was seen because he got to meet the criteria or the statute or limitation. And the purging time from active, inactive, close, now destruction. That's basically what it is. So it's serious. This is not something that we're going to take it lightly because it's the patient's information there. Remember, we now worry about the patient's diagnosis, medications. We are worried about the patient's personal protected information. Anything that can identify the patient is considered PHI, patient health information, patient protected information, always. So we have to be very serious about this. And we're going to keep all these lists of retained documents forever. Until the doctor who owns the office dies, sells the office, whatever it is. Still, we're going to leave it for the next owner. So that's basically how it works. We need to keep this straight. Okay, so it says right here, an employee who quit 2 years ago, telephones and requests that, calls and requests that copies of her annual physical examination forms, which she submitted while employed, be mailed to her home address. How would you handle this? Now, remember, this is not something that is going to come in your exam. This is just something that, the publisher created there. But once again, we do not just send medical records to anyone. I believe that according to the label standards, the patient must come to the office and request for them because remember, release of information needs to be signed up by the patient. Nobody else should be requesting for this unless there is a death from the person, but then you have to go through litigation. You have to go through attorneys. So hey, again, after a certain period of time, your medical records might not be there. Remember, it says employees' health records must be kept for 3 years. So if we, in 3 years, you're not coming to get your medical records, probably you're not going to get it. So there are certain regulations that we need to meet. But again, you can't just call into an office and request for something. You have to go there, sign a release of information, even though if it is for you. And then the doctor is going to release that information, not immediately. Remember, when a patient comes and requests for copies of their medical records for any reason, it doesn't matter what the reasons are. Not at this point, just request for his or her medical records. Well, they have to sign the paper that we're going to go over, the release of information form, who is requesting it and for what reason, to who this information is going to go. You have to tell and how much information you want. What is the information that you need for the medical records? Then this form that the patient signed is going to go to the doctor. And the doctor is going to make a decision when it's going to release this. Usually takes between 7 to 10 days. This is not immediate. No, we never give a patient copies of the medical records without the doctor's authorization. And the doctor never going to read, because the doctor is going to go over the entire medical file, is going to read every single detail, is going to make sure that all the information is there. There is no missing information, because that can be used against the practice of the medical doctor. And then the doctor is going to decide what information is going to be sent to the patient. It is up to the doctor's discretion, not us, not the patient. Oh, I want the entire medical record. Yeah, you're going to get the entire medical record, but there are some things that you're not going to receive, because that's how it is. And again, we need to understand the law, because that is the law that requires what information we can release, which information we cannot release to the patient. Now, please, I'm telling you this, but this is not something that you're going to tell the patient. Oh, well, you want the whole medical record? I don't think so that you're going to get the whole medical records, because the doctor is going to decide what information is going to give you. That is not something that you have to reveal the patients. This is medical. This is how it works. This is the law. But we are not telling our patients. That's all. No problem. You complete the form. Just you need any help completing the form, I explain it to you. Not that I'm going to fill it out for you, but I'm going to help you out to understand certain questions. And then it says, oh, they're asking me, what is the reason that I need the medical records? Yes, they want to know, what are you going to be using the medical records for? Are you going to take it to another doctor to follow over there your treatment? Are you going to be using it just for your own good? You just want to keep it because you're moving, or you're just not going to come back here? What are you going to do? And it has to be written in the form, because if it's not written, the reason, or you make up a reason, no, I'm just going to keep my medical records for myself. And then they use the medical records to sue the office, that medical record is invalid. Cannot be used because you lie in the form. So you can come to my office and tell me, oh, I need my medical records. That's for my own knowledge. I just want to have it. I might be moving soon. I don't know. So I just need it for me for now. But then you use it against me to suit me or to suit my office, my practice. You're not going to be able to do it. That's what you have to explain to whom and for which reason you need this medical record. Remember, the law goes, both ways. It helps you, benefit you, but also the medical practice. So people think that, because we're going to talk about now what is, who's the owner of the medical records? Who owns the medical records? The practice is mine. I created it. Wait a minute. But that's my information. I gave you all the information. Sure, the information is yours. But you cannot take the medical records with you just because the information is yours. So we have to make sure that we do understand exactly what a medical record is. This is what this class is all about. This class is not about just memorizing some statements because I'm going to pass the test. No, it's understanding whatever is going to happen in your office if a patient arrives or claims that they need this and they didn't get this or something else. So it protects the patient, but also protects the medical provider. All these laws are made out with that purpose in mind. So we got to make sure that we have everything straight before we do something. And I'm telling you this because I have one of the medical assistants releasing a medical record, actually giving the medical record, the original, to someone who claimed was the attorney of one of the patients. I was there and I could stop this. Otherwise, we have lost the medical record. This medical record cannot leave the office. If you want a copy, we can give it to you. Not now. You have to wait until the doctor evaluates every single page that is contained within the medical records. And then we're going to let you know about the copies that you're going to receive. Wait a minute. You have to pay for each page of the copies because the copies is work, is money. So the office charge is legal, $1 per page. So if you have a medical record that have 100 pages, you're gonna pay $100. So that is how it is. It's by law. Even though if the government requires them, they bring a check. Oh yeah, when the copies are there, how many copies? Oh, 100 copies, 200 copies. Okay, here it is, the $200, $300, whatever the case may be. Because they are the law, they create the rules. So therefore they know. If the patient requested, they're gonna pay for it. We'll have some exceptions to the rule. For now, they gotta pay for it. Any questions about releasing the patient's information? Because this is really, really important. Remember that I told you, and when I tell you cases, situations that have happened, when I was, active in medical, I saw many things happening. And remember, it's not just the doctor that's gonna go down, it is you. Because you release the information without the patient's authorization or without the doctor being authorizing you to, and then you're gonna get $200,000 fine and at least 1 year jail time. This is the HIPAA violation. This is not a joke. This is not something that I made up. This is not something that the office is made up. No, this is by law. So you're going to be losing. It's not like, oh, well, I didn't know well. Remember that excuse that I was ignoring the rules, I was ignoring the law. It's not going to save you for paying the price. So we need to know, and we need to make sure that no matter who comes to the office requesting for information, if you are not the patient, we're not going to give you that information, period. And if it is the patient, okay, no problem. Here it is after I confirm that this is the patient. And it is in person. Patient has to be face to face. It's not someone calling me over the phone or sending me a text message or an email. No, it has to be in person. And signing right there in front of me when you are requesting and filling out that form. Then you're gonna wait 7 to 10 days for this information, to these copies of the medical record to be released to you. Copies. We do not give the original one, belongs to the practice. Who created belongs to the doctor, belongs to the hospital. The only time that this copy is gonna leave my office is if we have a court of order, we have a subpoena. Remember, subpoena is this court document that requests information to be sent from the office to the core. In that situation, only in that situation is the only exception to the rule. It was medical record was subpoenaed by the court. It is a court order, we have to send it. But before we send it, we make copies. We keep a copy. This is the reverse for the patient. Patients never receive the original. Nobody receives the original. If the court does not request, does not subpoena the medical records, no need for it, but they will. If it is the case, they will subpoena, because that's how it works. Okay. So basically, this is what we covered for this chapter. We talk about organization of the medical. We talk about what is the medical record. Remember, very important to know what is it within the medical record. Why do we keep a medical record? What is important to do that? Well, remember, this is when we keep every part of the information from the visits, treatment, medications, anything that the patient have gone through by the time that the patient has been seen or being seen by our medical providers. And this is information that's very important, because who remembers every single event, situation from the patient, from the time that the patient's, starts coming to our office? It will be impossible. That's why we have books, because we're going to use them as a reference. Everything has to be written. Everything has to be documented. We're going to learn how to file them, again, how to organize them, because if we don't not organize them, we're not going to know where they are. And it's going to take too long to find these medical records, and we don't have time. When the patient arrives, we have a measure, certain period of time to spend with the patient, 10 minutes, 15 minutes, 30 minutes, 45 minutes, depends of the reason of the visit. So by the time that you reach looking for the medical records, I'm not going to be seeing, we cannot see a patient without the medical records. Impossible. I will not start seeing my patient until I have the medical records of the patient in front of me, where I'm going to document this information. I have to have it, because I have to read what's been going on with the patient. How do I know what's going on? Now the patient comes with a different complaint today, but I don't know anything about this patient prior to that. Yeah, I've been having these patients all the time, but I don't know anything about the patients until I see. I glance, I scan over the medical records, I'm going over, oh, I remember this patient, what it is. I don't remember the patient well, personally, but I see the condition. So now what you have, I'm going to compare what you had before, and now I'm going to make my decision. So I need the medical records. And if you don't find it, then I'm not going to be able to see the patient, and the patient is not going to be happy. And I'm not going to be happy because of the medical record. And you're not going to be happy because I'm going to put you to look all over for that medical record. So nobody's going to, we have to be organized. Definitely. We have to be organized in different types of organization, equipment, systems. So we need to follow all of those. Remember, we talk about how to purge these medical records. Purging is very, very important, so we can eliminate problems in, having all this information or medical records when we're not supposed to be having it. We need to remove whatever is not active and whatever is closed, put it away, so we don't have too much stuff to look through. Remember, we talk about using the OWL guide. Remember, the OWL guide is this particular kind of, divider that we are going to use every single time that we remove a medical record. We have to put it in place, but it's not just putting a divider in place. It's supposed to be writing a note in a little pocket that it has the divider. We're going to place a note right there. Who requested? To whom this particular medical record went, when, what time, and who released, who removed this medical record. So we know where is it. That's organization, remember. So this is very, very important. So that's mostly, the summary of what we covered. And we just went over, the retention and destruction scheduling for medical records. So this is important. We are going to go back to most of the things during this module because it is relevant every single time that we talk about one thing. We're going to bring it back, and because it's needed, most of this information is kind of intertwined. So we need things from the beginning, from the middle, from the end, and so on and so forth. Okay, so we're done with this chapter. Oh, let me see. Still too early to go on break, so let's move on to the next chapter. Any questions up to now about medical record management? Remember, feel free to ask me every single time. Stop sharing. Okay. I'm gonna just post the new chapter. Okay, so let's talk about more details about the paper-based medical record, because it's important for us to understand. When we understand the paper-based medical record, we have a lot of information that we're gonna be using for electronic medical records. It's just in a different format, but it's identical. Just gonna have certain variations because now we're gonna see it electronically, but for now, it's just paper. So we're gonna talk about the content inside the medical record, medical chart, medical files. Remember, this can change names, depends on where you're working. If a doctor or the nurse or the office manager or one of your coworkers asks you, said, "Oh, can you give me the file from patient Mr. Johns?" Well, they're talking about the medical records. They're talking about, "Oh, can you hand me Mr. Brown chart?" So they're talking about the same thing. We don't just use one term, medical records. It's medical records, chart, the medical files. So again, get used to and learn, because that's basically what it is, process that we're going to be following. So introduction of this new chapter. So we talk about these medical record management systems, but we also describe that if we don't follow all these management organizational systems to maintain privacy, confidentiality, security of this information, in collecting this information when it's needed, documenting it as accurate as possible, then we don't have anything. So we have to have this. And it's going to be easy to be retrieved fast. Remember, if we do not organize things, we're not going to have, things being done in a timely fashion. We're not. So we need to make sure that we keep all these organized. And of course, we have to follow all these policies and regulations of our organization. So when they request for medical records, it has to be there. Period. There's no excuse that I don't find it, because see, this is the problem that we don't want to confront, because that's going to once again put back treatment. It's going to put back the patient's appointments. So now I'm wasting time waiting for the medical records. This patient is not being seen. Time is running. Now the next patient is not going to like it if they have appointment following that one, but the other patient still we look in the medical records. And the patient is not going to be happy. Remember, it's not the patient's responsibility. The patient just comes to our office and we need to have that information available so the patient can be seen, whatever has to be done, and then patient can be dismissed without any inconvenience. So we have to do that. So we're going to discuss during this chapter the reasons to keep accurate medical records, meaning the information. What has to be accurate? Makes sense, right? Everything has to be accurate, but we're going to discuss that. We're going to talk about the ownership of the medical records. Questions for exam, 100%. Who owns the medical records? Who owns the information? So we're going to talk about that. Differences among types of records. We're not talking about the filing, not again, that is the past. We're going to talk about how do we document information in the patient's medical records. That's basically what it is. There are different styles or types. We have two of them, very simple, but we need to know the difference between them because these are questions for exam. Differences among types of information. Of course, we have different information. We have information that the medical doctor collects from the patient about conditions, symptoms, signs that the doctor discovers, medications, diagnosis, treatments, different information. Different labs. Blood test is not the same as a urine test, or it's not the same as a biopsy. A fecal test is not the same as an X-ray, CAT scan, MRI. So we have different information. The information that the patient tells us is not the same as the one that we gather. It's not the same. The findings that I have when I evaluate my patient is not the same what the patient is telling me, because I see things from the viewpoint as a medical provider and the patient seeing as themselves. What is it that they have it? So we're going to have correspondence from different doctors, laboratories. So we're going to have lots of different information. Now, because we are documenting things and we are here. So if we make, how are we going to make corrections in a paper-based and electronic medical record? How do we correct anything that was done wrong? Those are going to be questions for exam. Forms found in the medical records. We're going to talk about the release of patient's information. Oh yeah, the lab results, the registration form. So we're going to have a lot of stuff. A lot of documents are going to be within that medical file. So we need to be familiar with. Oh, the progress notes where the doctor starts writing information when the patient comes in. So the encounter form, the super big, it's going to be a lot of stuff that is going to be contained. Labs. So again, that's something that we are going to be discussing right here. So the first thing that we are going to be discussing, again, we said already, is why medical records are important. Why do we have to document everything that the patient tell us when they come, for the visit? And why do we have to document everything? Is it really important to document everything that we hear from the patient? Yes, of course. Because without that information, how we as medical providers are going to be evaluating our patient? It says right here, assist the physician in providing the best possible care to the patient. Of course, if I have a documentation, I'm going to know what is it that I did or who did what last time. So I know that I'm not going to repeat the same test, or I'm going to repeat it because I need to know something. So we're not going to waste time copying or collecting the same information over and over. Not because it's not possible, because it's a waste of time and because we don't recall things. Ask a patient, ask yourself, oh, do you remember the last 10 years ago when you went to the doctor? What is it that you have? How I remember that? But if it is documented, we're gonna be just reading it, going over, and then we refresh our minds. Now, me, I'm not the one who suffered the condition. I'm not gonna know if the patient that suffers the problem is taking the medications, have the medical condition, doesn't recall anything. How I'm gonna recall that is not my problem. Remember, this is not about memorizing things. It's about keeping things documented for legal purposes, for education, for research, for financial purposes. So we're going to see all that. Offer legal protection to those who provide care to the patient. Well, remember, we have been talking about this all the time. If the patient sued the office of the medical doctor, the first thing that is required is to bring the patient's medical history, the patient's chart, the patient's file, the patient's medical record. That's the first thing is going to be required to be presented as a proof. So if it is not well documented, if it's not accurate, if it is missing information, then we're going to be in trouble. We're going to be losing the case, not because we are guilty for something that we didn't do. Probably we aren't innocent. Probably we have nothing to do with what happened to the patient. But not having the information correct or complete, that's going to create a problem. So again, this is going to save us a lot of trouble. Remember, I gave you an example, very common example. It happens to all of us all the time. We buy something in the store, we go shopping, and then we don't like that particular article, product, whatever the case may be. You're going to return it, right? But if you don't have the receipt, guess what? No proofs that you bought it here. Oh, but no, nothing. I need a receipt. So that's basically what it is. So that's gonna kind of, put things in a very difficult situation. Another reason why we need to document them in the medical records is because it provides statistics or statistical information that is helpful to researchers. This is the book. This is part of the research. All these books were written based on conditions. How do we know all this about the medical records? Because it was from there that we got this. I'm telling you everything without mentioning any patient's name. Oh, this is the condition of this patient. No, we're not revealing any of that. We're just talking about why do we need all this information to be collected and to be accurate. Because there are many things that can be, that can be required for. So we need that. How the pharmaceutical companies are going to manufacture a new medication, a new equipment. How? If they don't have information about what's going on with the patients, what conditions are. So if there is no information whatsoever there, well, it's not going to be no medications. It's not going to be new equipment to treat this, to do this or that. We didn't have any of these state-of-the-art equipment. And every day is changing. Why? Because everything is changing. A medication that was working for a condition back in the days is no longer working. Now we have a different medication. Probably we have to add another medication. So that is based on all these changes about conditions, and now we document it. So we know how many people have this condition. Remember that we talk about which conditions we need to be reporting to the CDC, because they keep this statistics about how many diabetic people do we have in each town, each state, from which hospital was diagnosed, and in general, the entire country. And then this is being reported to who? The World Health Organization. And then they're going to have statistics for the entire world. So we know we have statistics, how many diabetic people are in Italy, in Spain, in Portugal, Brazil, Argentina, not just America or North America, all the Americas, Europe, Asia, Africa. We have that. Every single condition, we have statistics about those. So that's what's important, to keep the patient's conditions, procedures, medications up to date, because it's going to help us. Vital for financial reimbursement. Well, when we document something, the patient comes to me doing certain evaluations. I might order some tests if it's needed. If I need reimbursement, I have to tell the insurance company, what is it that I did? What is it that I did that I'm charging for it? So I have to give them a summary of everything that I did. And it has to be written in the medical records. And from there, I gather the information and send it to these insurance companies, so I can get reimbursed for my services. That's how it works. But without this information, you can't just bill for services and then the insurance company is going to say, okay, so you said that you want $10,000 for this patient. What did you do? What is the $10,000 for? Once again, since you go to the store and you buy groceries, they're going to give a receipt, and there you have every single item that you purchase and the cost of each item. So that's like we do in the hospital. For each item, we charge. Oh, basic, we charge this much amount of money. Oh, blood. What bloods you did? Urine. Okay, what test was that? Not because it's urine, just because it's blood, it's going to be the same amount of money. No, all depends what test is ordered, for which condition, what type of urine test, what type of blood test, what type of biopsy, from where, what type of procedure, because all that costs money. So we're going to charge for that, not just the time that we spend with the patient, but what was the, the seriousness of the condition, so to speak. Because we need to kind of prove, why are we charging for this? So we need to present records for that. And it's going to be documented and it's going to stay in the medical records. Every single charge claim that we do to the insurance company, we keep it in records. We have to. If something happens, we're going to prove what is it that we got paid for. And, we can have an audit. An audit is when, the insurance sends their people to go investigate the government to see whether you are committing fraud or not. They're going to review those medical records. If it is a lawsuit, they're going to review those medical records to see what services were provided. Are you charging for the service correctly, or you just upcoding or downcoding to cover for services probably that you didn't even provide? So we need all this information. So it is very important. not just to follow the patient's condition, treatments, but there are many other things that we need to show proof just in case things arise. But we need to know. I check my bank statements all the time. Why? Because I need to know how much money I have still left. I'm not going to be buying like crazy and then says, oh, wait, listen, decline, you don't have money. No, we have this balancing, statements that a monthly you receive. So you got to make sure that you receive it. You don't go overboard. You're not going to go overdraft. So again, it's the same thing. It's just there's a different setting. This is medical, and this is something that can get you in trouble. And it's something that can get you in trouble if you are paying for something and the bank declines to pay because you don't have enough or sufficient funds. So it's the same thing. So think about it. You have to keep records so we can prove what's been done, what is being charged. If that really the charge applies to what have you done or not. So that's basically what it is. There are lots of things that we can do. Let's talk about the ownership of the medical record. So remember, these are questions for exam, 100%. 100%. So you should know it. So remember the medical records. Think about this when the patient comes in. Do they bring anything with them? I said, oh, well, I want to make an appointment. I want to, have my services provided here in this practice. Oh, sure. It's your first time? Yes. We're going to create a new medical record. We're going to ask you for a lot of information. We're going to make copies of your insurance card, your driver license. We're going to ask you personal information, medical information pertaining to you, patient's information, family information, social information. We're going to collect a lot of information. So you're giving us the information. So the information is yours. So the patient owns the information that is contained within a medical records. Pay attention, because every single time that I gave my students an exam, they mix them up. Who owns the medical record? The patient? No. Patient do not owns the medical records. The medical records are the physical documentation. That's why we keep these files, these medical records, these charts in the office, in the practice. They cannot live there. They cannot leave this place. Patients do not bring the medical records and then goes back home with the medical records. So think about that. So the physician, the medical facility, the hospital, whoever creates the medical record is the owner. So pay attention carefully, because we always get distracted. A little something there and we distracted, make a mistake. When I said the medical facility means a hospital, a clinic. Remember, hospitals do not have an owner, one person. It's not the doctor. Doctors in hospitals, they work, they are employees of the hospital. So read the question. When you see the question reads as follows. Patient is being seen by this particular hospital. Who owns his or her medical records? The hospital. Not the doctor that they've seen. No, it's the hospital. Because hospitals, the medical doctors do not own the hospital. But if they tell you the medical office, the doctor's office, who owns the medical, the doctor, because that's his or her office. That's their institution. Hospitals have many owners, so we're not gonna point on one. We just call hospital. Usually we don't say, oh, I'm gonna go to Macy's, because Macy's have stand-alone stores, right? But usually said, I'm going to the mall, and it contains a bunch of stores within. Well, the hospitals are the same. Contains different specialties over there, but each doctor that see us, they do not own the medical records. It is the hospital, because we work for the hospital. Not that we own by them, but eventually, hypothetically, kind of, we work for them, but we're not the owners. So the doctor owns the medical records in the doctor's office. In a hospital, the hospital owns. In a nursing home, the nursing home. This is an institution, it's big. It's not one doctor. So keep that in mind. So when they ask you a question, who owns the medical records, they're gonna say, okay, the doctor, the patient, because they're gonna distract you, right? And then they say, the institution that creates that medical record. Independently, what else it says right there, that is the correct answer. Is whoever creates that medical record, that is the owner. But again, if it says hospital, it's the hospital, not the doctor, not the patient. Nonetheless, a family member. So again, if they ask you who the information we contain within the medical record, to whom it belongs, patient. What patient owns in the medical record? The information. Remember, the key is information, patient. You are the one who came and told me all your problems, so your information is there, printed. Who printed? Who's those forms from? Mine, the medical doctor, the hospital. So that's basically what you need to understand. And even easier, think about you do not take the medical record with you. Because if you will take the medical record with you, then you will be the owner. But every single time that you come to the office, you have to bring it, right? And then take it with you. That's not the case. You bring the information with us, and when you leave, the information goes with you because you own the information. Simple. So I'm giving you all these tips so you don't make mistakes, because these are very, very straightforward questions. And I want you to get the straightforward questions because it is easy. This is like, statute of limitation of medical records, 7 to 10 years. Oh, you don't see 7 to 10, 7 years. 7 years it is. You don't see 7 years, 10 years it is, because it's one of these answers is gonna be there. Straightforward. So get the straightforward questions out the way. Now the questions that has a paragraph for you to read and try to, understand. Well, I will take the chance, but I know that the other ones are good. But not only for that, think that you're learning a lot, that you know that when the patient asks you, oh, I need a copy of the medical records. Sure, you have all the right to have the copy of the medical records. That's what we think. You don't tell them. Said, sure, not a problem. Here is this form. Please fill it out. And you ask for, can I have your insurance? Can I have your ID? Just to make sure that this is the patient. Just because the patient says, I want my copy, and they say the name, does not imply that that might be the patient, might be somebody else. And you have to do the due diligence, remember. First, getting the patient's information. That's what we do when the patient comes, right? Oh, I need to make an appointment. Sure, not a problem. Oh, may I have your insurance card, please? Then we're going to verify if the patient that right there, we see the name of the patient. Can I have a photo ID? Oh, I have this person right here. I don't know this person. I haven't seen it before. I see so many patients. How do I know this is the actual patient? I don't know. So we got to do what we got to do. Remember, we got to make sure that, we don't violate the patient information. The patient itself can get you in trouble because they know how to get money from us. So they will trick you. So be on the lookout all the time. I can tell you that much. So don't think that, every single patient is going to go there with good intention. It is up to you, the professional, to make sure that you verify every single thing. When you go to the bank and you're going to remove money and you have your bank card, well, they're going to verify a lot of things. They're not just going to release the money to you just because you show up with a debit card or something else or the bank card. No, they verify a lot of stuff. I used to get upset when I go to the bank. It says, "Oh, can you provide this? I was like, "Oh, wait a minute. I've been coming to this. This is the only bank that I'm banking with. Not that the people has to know me, but just that's in my card is enough." Then I said, "Oh my God, thank God that these people is asking me all these questions, because what if somebody else have my car? I lost my car. Somebody stole my car. And they come right here and get the couple of dollars that I have left right there safe." That wouldn't be a good idea, right? So the same thing we have to do with our patient comes in, because we are protecting ourselves. Remember, this is serious. This is not a joke. I'm not saying it just because I want to say it. A HIPAA violation, even though if it is the patient that you give them information, and the patient sue the hospital or the clinic or the medical doctor because you did not request for this form before you gave them the information, guess what? $200,000 fine, 1 year in prison at least, if proven that that was your violation. It's not your medical doctor that's going to pay. For this, you're going to pay. So make sure that you take this seriously. Sometimes we think, oh no, that's not going to happen. It's not going to happen to me. Well, guess what? I have seen so many people getting into this problem. And remember, the least that can happen, let's say that the patient is not suing you or not suing the practice, but your medical doctor or someone else noticed that you gave this documentation to this person, they're going to turn you in. Guess what? You're dismissed. I will dismiss you immediately. I wouldn't even ask a question, because you're a liability. You're a problem. You can get me in a big trouble, in a lawsuit, because you just did that. You can do anything else. It doesn't matter. I'm talking about, listen, all the experience that I have had with other people. I don't have to go through all this to learn myself. No, I'm seeing it happen right before my eyes. Telling you. And most of the time is when friends or family members come. And you do things just because it's your family, because you're friends. Guess what? This is not always safe. Do what you have to do in your workplace. Keep the patient's information confidential, even though if it is your family. Don't give copies. Don't give results. HIPAA violation, HIPAA violation, HIPAA violation. So be careful with that. Okay, so medical records must be kept confidential and in a secure, locked location. Well, I don't know about a locked location, but yes, should not leave the office. Should not be left unattended on top of the counters, places somewhere where somebody else who's not a medical provider within the office can open it up, read it, and see information. Remember, sometimes it's not about the medical conditions that the patient have. Somebody might get the patient's personal information and commit fraud. Oh, I have the social security right there. I have the name, I have the address. Oh, well, I can do a lot of things. You don't know who is coming to your office. and you don't know what they need from this patient. Or they just look at the information and then, start spreading the gossip about what the patient has. Is the neighbor, is someone that they don't like, and they start spreading the rumors. And who is going to pay the consequences? Whoever spread the rumors, probably. But the target number one is going to be your office, nobody else. Because why is this person knowing that information? Because the information was left unattended, was not secure. You didn't keep this private or confidential. So that's the reason why. I already told you about this. The medical record never leaves the medical facility in which it originated. So it's a no, never. Exception to the rule, subpoena, court order. But this doesn't happen all the time. This is, well, only if the office gets sued, not because it gets sued, it goes to trial. Now you have to bring proofs. So it's very important. You should not take medical records. You should not give it to the patient. If a medical doctor is doing that, keep it. If something happens, write it down somewhere. And if something happens, you might have to be a witness, testify. So again, it's our responsibility to keep the practice safe. Remember, you work for the practice. Sometimes the medical doctor, the owner of the practice, they know that they're not supposed to be taking these medical records away. Remember that I made a comment last time that, I was working for this particular practice, and one of the doctors took the medical records home because they didn't complete all, the history of treatments or whatever. Says, oh, no, I'm not going to stay here. I'm just going to take them home. Well, that's what I assumed they did because that's what happened most of the time. Well, if you couldn't complete them, you have 24 hours to complete them. So come back the next day, don't see patients for 1 hour and do this or during your break. I don't know, but you got to complete them there in the office, not taking them. Now, the problem was that patients start coming in to look for, to get medical care, and we couldn't find the medical records. And it turns out that this guy has it. And guess what? The person never say anything. We found them in his card trunk. Can you imagine? So again, this causes a lot of trouble for the office. Now we couldn't see the patients that without a medical record. Remember, if there's no medical records, we're not going to be able to see them. We can't just write in a scrap paper. It says, okay, I file it when we get it. No, it doesn't work that way. Because if the chart, the medical record never is found, guess what? What are you going to do with that loose paper? What are you going to do? What are you going to tell? So that's malpractice right there. So again, you need to understand the whole concept. It's not just, oh yeah, we have to have the medical records. Yeah, they should not leave, but what is the reason? What are the problems that are going to arise from that simple mishandling? Because that cannot say mistake, that's mishandling of something. Okay, creating an efficient medical record system, of course, should provide easy retrieval. One of the most important things when we create medical records, not only being accurate, the information that we enter there is, that is easy to retrieve. That we're gonna, when we need it, we can pull it out from the shelves, from the cabinets, whatever. equipment for keeping these medical records are in our office. We can organize them in order. Well, if they are in this array, we're not going to be able to find them, right? Again, that's what we have these systems to organize these medical records by numbers, alphabetical, numerical, or alphanumerical, color code, terminal numbers or digits. So we can create these with purpose in mind. Otherwise, we just throw them anywhere and then spend hours trying to find the medical record. That is not the purpose. Now, the information within the medical record has to be legible. We talk about this. Legibility. This was, well, what I said right. This was one of the reasons why the government wanted to move from paper to electronic, because now the information that is contained within the medical record is going to be legible because it's going to be print. So that's basically what it is. I don't know if you have ever tried to read the medical handwriting. Sometimes when I moved to this country, we didn't have medical records yet. They started few years later. So we were writing everything by hand using a pen. So to be honest with you, sometimes I was writing things and I was like, oh my God, I cannot even understand myself, my handwriting. How is I'm going to expect that somebody else is going to be able to read it? A colleague of mine. Because remember, these medical records can be used not only for the medical provider that has been writing them. No, they ain't making the entries. Anyone in the office might need this for billing, for referrals, for sending something to the lab, for insurance. So if we do not understand this is not legible, that's going to be a big, huge problem. That's what mistakes are made. And that's one of the reasons many people, got the wrong procedure or got the wrong patient. So because it wasn't illegible. So basically, and I was through that. I have to read somebody else's medical record that was written by someone else. And when I tried to read it, well, some of the things looks alike, but that's the problem because there are many procedures, medications that they just look alike. And then it says, oh, it ends in this. Oh, so it's got to be this. It's kind of guessing. That's not good. So it has to be legible. And it was done with the purpose, of course, not first because we didn't have, computers at that time. And who is going to be typing all this? Using a typewriter, that's going to take forever. And second of all, because they didn't want other people to understand what was written there. So I believe that was the major reason. So if somebody encountered a medical record, I wouldn't even want to try to read it. And not being a medical record adapter, it's difficult to read somebody else's handwriting. Can you imagine not being so? So that was the main idea. But that was an idea done, because we didn't have computers. We didn't have a system that facilitates that it was fast enough, that was legible, but people can actually use it. So medical records came about, electronic, so now things have changed. So legibility was a huge issue. Now, once again, contains accurate information. It has to be accurate. You can't just put there your opinions, what you think, your assumptions, your bias statements. No, that's not for that. It's exactly for all your findings and the information that you collect from the patient. And what your decisions are going to be about diagnosis, treatments, and so on and so forth. So it has to be accurate and it has to be documented on time. So again, what's the problem of someone not entering the information right after interacting with the patient? What's the problem? You're going to forget. Because now you're going to have the information from your next patient in your brain. Now that's going to be like scrambled eggs in your brain. Oh, was this patient or the patient who told me about this or that? Oh, I'm going to mix them up. So that's not going to be accurate. So I'm going to be doing the entrance. I'm going to be entering that information right after or during the evaluation to my patient, because that's how it should work. And then you can, move to the next patient. Show information that is easily understood and grammatically correct. Okay, well, easy understood for the medical providers. Yes, not for someone else who does not know medicine. But yeah, because if I need to use, once again, the medical records written by one of my colleagues, I need to understand what was written, what information was entered, what was collected, so I can follow up from them after. Of course, we have to use good grammar, remember, that makes sense. Spelling. Because once again, there are certain terms that they sound the same, but it doesn't mean the same. And they might be written almost the same. So we might make mistakes. So every single time that we do an entry of documentation, we have to proofread this information. Doesn't look good that medical doctors making mistakes. If this medical record ends in the hands of the court, we're going to be in hot water right there. Because grammatically, it's not correct. Whatever word that you try to imply, you said, no, what I tried to say is this, but it was written different. Okay, so we have a problem. So that's basically what it is. So it's not just making an entry on the medical record, just writing things down. No, it has to follow certain patterns, certain criteria, certain regulations. And following then, it's a little tricky, but we have to do our best. One of the good things about writing medical records is that the statements are very brief. This is not writing an essay. What is the reason for your visit today? Headache. Okay, there is headache right there. Back pain. I have a rash right here. I have this redness in my leg, in my arm, my legs, something. I cannot hear well. I cannot see. I have a cut. I have an injury. I have a trauma. I fall. Well, it's very brief. So it's not like we're going to start describing every single detail. Yes, how do you fall? Now, again, it's going to be brief. So we need to go to the detail, not the whole story. Because it needs to be that way so the other person can understand without having to read the entire essay. So this is an idea. We went through this already. We have these open shelves when we place these medical records. Remember, they are labeled regardless of what type of filing systems they have. But the purpose is to organize them in an order that when we need to remove them, they're gonna be very easy to retrieve. Retrieve is pulling them out from the shelves, and then we're gonna put it back. That's retrieving, removing them from the shelves. And remember, here is when we're gonna use these our guides, where it's gonna be replacing the medical chart that we're going to remove. If we will remove 10 medical charts, well, 10 our guides we have to place there. If there are 100 our guides needs to be placed in there. And then put it back exactly where it belongs, so we don't mix file them, because that's going to be a problem. When we are going to look for it, we have to look through the entire row to the entire place to make sure that, we find it. So facilitates more the way that we are going to retrieve this. So that's important. It doesn't look like sometimes when we think about it, oops, said, oh no, that's easy. Oh, I just place it right here. No, there are many medical charts right there. One thing is seeing the shelves, the cabinets filled with all these medical charts. But when you're gonna go look for them, things are different. Because I have, I know how it works. Not to mention that, these are paper, and then you put in your fingers everywhere, and you cut your fingers and all that stuff. So not good at all. So that's basically what it is. So let's talk about these types of records. Now, remember the types of records right here. We're talking about what is, the criteria for entering information in the medical record. So what is the first thing that you ask? What is going to be written? What is the second thing that you're going to ask the patient? What is going to be written? Where the labs are going to go? Where the blood test is going to go? Where the urine test is going to go? Where the correspondence is going to go? Where the referrals are going to go? Where the registration form is going to go? Where the patient's information, social, medical, family history is going to go? It's going to go somewhere. But you just cannot place them wherever you like. It has a specific place. And all the documentation has to go in these particular sections of the medical records. So it is easy to retrieve again. The doctor tell you, okay, Maria, do me a favor. Can you go and look in this patient's chart and bring me the x-rays from this time, this date? If all these papers are mixed up, you have to go through all the papers in order for you to find that. Other than that, you just go to where x-rays are. Oh, labs, x-rays. Oh, good. Now, alphabetical order. Oh, I'm sorry, reverse chronological order. Remember, we're going to use reverse chronological order to file documents. What is reverse chronological? That the most recent visit, the most recent document has to be on top. That is reverse. Yes, it's chronological because today is the 18, though before that the 17, the 16, the 15. So we go there. So the last one should be today. And then the other ones are underneath. And the next one that comes next week, this particular day, the 22nd, the 24th, is going to be on top. Because that's how it goes. Think about a book. The first page goes right there when you open it up, right? But then when you go to the end, that's where you're left off. What is, I have written, well, I've been reading all this chapter and now I'm chapter 5. You're not going to go chapter 1. You're going to go chapter 5. So you pass all the chapters and you go to that particular page. And sometimes we leave there an outguide, right? A little divider or separate. because we need to go back exactly there. We're not going to be start looking pages one by one because it's going to take too much time. See how important it is? So paper-based medical records, computer-based medical records. So we are going to have paper right now. And then we talk about the computers when we get to that part, because we have a section for that. So let's talk about first the advantage and disadvantage of these two types of systems or medical records for that matter. So when we talk about paper, then whatever is negative, just to make it simple, something that it doesn't help much, it doesn't have many benefits, that's a disadvantage. Paper, first of all, it gets damaged. Think about that. It gets wrinkled, torn, the ink might run out, the papers might be loose, missing, a misfile placed in a different section of the medical record. Oh, a lot of stuff, right? What about using the medical record? Well, if I have the patient medical record, so this is the actual, paper-based medical record chart. And if I have this medical record and I'm working on it, nobody else can have it at the same time. See, that is a huge disadvantage. And I have to be in the office in order for me to get this paper-based medical record, because this I cannot take it home and I cannot go with this wherever I go. Problem. So if someone else needs this medical record at the same time, let's say, for instance, I'm working with my patient right now. I have the paper-based medical record with my patient. I'm taking the notes, I'm doing the examination, blah, blah, blah. A nurse needs this to prepare medications that are going to be given to the patient, because the nurse knows that this patient came with this condition. The nurse knows already that she's preparing herself to give a medication. Well, the nurse is not going to be able to prepare no medications until the doctor releases this patient. At the meantime, the nurse probably is not doing anything, wasting time. But if I have electronic medical records, guess what? The nurse is working directly on the patient, has the information, the medical doctor is working there, the billing department is already working in there, everybody's using the medical record at the same time because it's electronic. So that is a major disadvantage. Again, I mentioned the other one that can mean this file, maybe slip, it is not there, this storm, is so many things that can happen with papers that are loose, wrinkle, damage, so many things. Because when we move these medical records back and forth, this is paper. It gets damaged easily. And as time goes by, and the more people that handle this paper, it's going to get damaged. It is, definitely. Not only whatever is contained within the medical records, but remember, the medical records itself can be misplaced. So again, and if we don't find it, whoever else needs information from that medical record cannot do their job. So we cannot bill the insurance. We cannot add other files to this medical record. And most importantly, we don't recall anything about the patient. So when the patient come back next time, how are we going to know what is the history of the patient? So that's a huge disadvantage for medical records, paper-based medical. If there is a fire, it can burn out. It takes a lot of space. We have to be buying paper all the time, pens, writing down stuff. It's not secure. We can leave it somewhere on top of the desk of the medical doctor. Somebody else, if the doctor is not there, somebody else can come and look through the medical record. So confidentiality, privacy. So a lot of stuff. It has tons of disadvantage. I'm telling you. See, if a medical doctor goes on vacation, or just put it easy, medical doctor goes home. Immediately, they have a phone call from the hospital, says, hey, your patient, Mr. or Mrs. Brown, in room this, blah, blah, blah. You ordered a medication, but the nurse do not find the order. The nurse is confused. Or the patient has this, and we want to order the medication. Well, if it is paper, I have to go back there and do it. But if it is electronic, I can do it from my home. I just enter the system, I have my login, I just enter the portal, I just place the order, read the information from the patient. I can read the medical record from my home, and then place the order for the medication that is needed or the procedure that is needed. And then I'm gonna go back and do whatever I was doing or back sleep. If it is paper, I might end up having to come back. Again, you can't just say, oh no, leave it for tomorrow. Tomorrow I do it. Oh, listen, I'm on vacation. I come back in a week. So I'm out of the country. What are you gonna do? Oh, we don't find this information. Do you know who got it, who you talked to? If it is electronically, many things can be done. So tons of advantage. We will talk about those when we get there. More than one person, see, this is the electronic part. More than one person can use the record at a given time. Like you and me. All of you are from different places. So you see me or you taking my classes. But if it was the case that we have to go in person, well, that's a different issue. Maybe not all of you can make it. This you're doing from, the comfort of your home, or sometimes from work, whatever the case may be. So it is convenient. So again, anybody who needs this information at any department, someone else needs this information, they can have access. Thousands of people can have access at the same time. This is like watching a movie on TV. Whoever wants to watch the movie is seeing it from any part of the world that wants to watch the movie. So we're seeing it at the same time. It's being aired at the same time. So you can see it because it's electronically. So that's what it says right there. That the medical records can be accessed from anywhere as long as you have internet. Easy to do it. Now remember, so you're not going to be accessing anyone's medical record without a login. So you have to be, allowed to, you have to have permission for this. So again, whenever you have situations that are very serious for our patients, can you imagine trying to, the patient just arrived, and probably the patient has a medical record here in this hospital because the patient lives in the area. Now we need the medical records. We have the name of the patient with information, but it's paper. Now we don't find it. Someone else have it. Wow, we're gonna have a lot of problems. But if it is electronically, we just enter the patient's last name, first name, or medical record number, and then here we go. We have it. This is an emergency. This is time that we don't have time for waiting for medical records. And we can't just do any treatment because we don't know what the patient has. But we do have the medical records, but it's not available. But if it is electronically, now we can go immediately and save all this time and all this preliminary testing, because we already know who the patient is and what medical conditions they have, what medications they're taking, what surgical procedures they have in the past, anything about the patient. Just to mention something important, we know if the patient is allergic to something. Not that we don't know anything about the patient. So this is really important for us to understand. So if we understand this part, we're going to be able to understand the purpose of the medical records. Okay, so let's take a break. Let's take 30 minutes. We come back 7:30. And when we come back, we're going to continue with this chapter. Okay? Enjoy your break.
Thank you, teacher.
All right. See you 7:30. Okay. So you're back. I hope you guys enjoy your break. Okay, so we are going to continue with these paper-based medical records. So let's go back to these two type of sources of medical record. Oh, let's go back. We were talking about the advantage of medical records. So let's talk about of the organization of the medical records. So we have two types of medical records. We have paper-based, computerized medical records. Either of these types of medical records can use this organizational method. So whatever we use in paper medical records, we transfer it to electronic medical records. It's just that it is electronic instead of being in paper, but the whole format is the same. So we have one type of medical record that is called source-oriented records or source-oriented medical records. Problem-oriented medical records. Now, this is important because you will be asked. In your national certification, you're going to be asked the types of organization methods that we use, whether it's electronic or whether it's paper. They're just going to ask you, okay, medical records are organized in this fashion, source-oriented or problem-oriented. So think about this. The word, the type of format, it tells you exactly what it is. It says source-oriented. The other one says problem-oriented. So that gives you the answer. Let's discuss source-oriented medical records or just records. And then we go for the problem-oriented records. So here we have information about record system, the source-oriented. So once again, you can have a source-oriented, but most of the time, as I have seen it over and over, and this is what we use in the past, even though things have changed a little bit, well, SOR usually is not what you're going to be seeing. It is source-oriented medical records, SOMR. So usually that's how appears on the test and literature, anything else. People just want to kind of, simplify things, but still for the exam purpose, you're not going to be seeing SOR, you will see SOMR. So remember, MR stands for medical records. SO stands for the source oriented. Now, this is the system that is most commonly used for medical doctors or the practice or the medical hospital. Now, why is that? Because when we talk about the source, we are actually organizing all this information in the medical record based on source, not in the problem. And it's the most commonly used because we're going to find all these compartments on a medical record that is going to start with patient's information, then patient's present medical history, so whatever pertains to the patient, but medically speaking, then history, patient's medical history, patient's social history, and so on and so forth. Then we're going to have the progress notes, then we have the laboratory, and then we have the correspondence at the end. So it's going to have this source of things that we're going to do. So when we are going to retrieve or we're going to be placing or making an entrance, we're gonna find it immediately. So let's say that you're gonna make an appointment for the patient. You open up the system, you have the system there, so it's like just log in with the login and passcode that you're gonna receive in your office. If it is paper, well, we're gonna do it in paper. You just open the medical records and says patient's personal information on the top, because it's separated. It has sections within the medical records. So you're gonna find one section, then another section, and everything is gonna be organized in that fashion. So if they ask you for the labs, it's gonna say laboratory or labs. Then they're gonna say urine, blood, any other type of body fluids, and then they're gonna go X-rays, CAT scans, MRIs. So if somebody asks you for something, you're gonna find it. Progress notes, they're gonna say they are progress notes. So whenever you need to find something about the patient, you just go to that particular section because it's source oriented. So it's a lot easier to find information because you go directly to that particular section. It's like the books. Think about a book and they said chapter number 1. You go to chapter number 1, you read everything about chapter number 1. Then it says chapter number 2. You go to chapter number 2. So you are kind of dividing all this information, all this data in sections, in chapters. So that is basically what we have source oriented. Again, it's not difficult. It's very easy to follow. Now, nothing is perfect, right? So it says right there, advantage is the speed which a specific sheet of information can be located. Well, yeah, just that's what I said. It's very fast to find information or to enter information because you go directly to the particular section. Chapter 1, chapter 1, chapter 2, and whatever is contained within that chapter. Once again, you go to the latest. So if you're gonna find something, you're gonna go in reverse chronological order. So that's basically what it is. So you remove something from there, you're gonna be able to put it back in the same place because you're following a reverse chronological order. Remember, reverse chronological order means the latest visit, the latest information, the latest test is gonna be put on top. So that's how it works. Now, disadvantage, well, everything has a little problem when it comes to paper. Some of the papers might be filed in different sections because it's paper that comes from the technician, from the nurse, from the doctors. If you don't want to place this where it belongs, that's a different issue. They ask you to read chapter number 1 and you go start reading chapter number 3. That has nothing to do with the system. It is with the person who is doing that. So again, we're gonna group everything based on source. Patient's information usually goes first. Then we have the patient's history, the patient's family history, the patient's social history. Then we got the progress notes, then the labs, the procedures. Last, we have any correspondence that we have received for the patient, for laboratories, from other medical doctors, letters that we send or reminders to the patient, whatever notes we have. So again, it's very easy to follow. Most of the medical providers in offices, hospitals, we follow this one. So that's basically what it is. It's not a major deal. It's just how the information is organized inside the medical record. So we have sections and we go directly to those sections. So it's a lot easier to get the information from there. This is like organizing the medical records using alphabetical order. So, or numerical order. That's what we use, these systems of filing. Here is within the medical record. where are we going to put the labs? Which labs? Is it blood? Is it urine? Is it fecal material? Is it a biopsy? Or it is an laboratory imaging? Oh, is it a CAT scan, MRI, X-ray, sonogram, and so on and so forth. This is the notes from the nurse. Okay, nursing notes are going to be in certain section. Provider, medical doctor notes are going to be in another section. So it's going to be very easy to open it up, go to the section, get the information that you need, or start entering the information on the top part of that information. So that's how it's done. It's a lot easier. So this is problem-oriented. This is source-oriented, remember. Now we go to problem-oriented. Now, problem-oriented, on the other hand, is about the problems of the patient, the conditions. Oh, I have a headache. So you're going to go and you're going to document headaches. I have a back pain. I have a rash. I have something else. Whatever the case may be, whatever complaint the patient have is going to be ordered using that particular method. Now, this is going to be a little more difficult to find or retrieve information to go back and place it because it's going to be a little troublesome. So let's assume this. Remember, we have the medical record right here. This is the patient's file. It is open. So here we have one tab that it says patient's information. Okay, so the patient information is not a problem. Then the next page on the front, we're going to have another tab that is going to say right here, doctor's notes. Okay, here's where the problems are. And from then on. So patient came today with a back pain, right? So I'm going to write down when it says back pain because it's based on the problems that the patient has. It says back pain, and that was like 2 years ago. Now, next problem that you have is you have urinary tract infection. That you have it like, 3 years ago. Then remember, these conditions sometimes don't happen all the time because these are something that may repeat, may not. It's not like diabetes and all the stuff that you take medications. So let's say that 3 years later, the patient comes back again with back pain. So I have to go where is back pain, not continue with the reverse chronological order. So the other one will be right here. No, I have to go back here and add it in front. So next time that you have urinary tract infection, it doesn't matter how long it was, I'm going to have to go back right here. But in front of this, I have other issues that I have the patient being seen during all this time. So again, you have to go back to the problem and start adding the pages within the problem instead of putting all of them on top. So you go by dates, not by problem, by condition. So that's going to be creating a little problem because now you have to go exactly back to the particular page where is that particular problem. So that is going to create issues because now we are not following these goes on top of everything, the reverse chronological. It's going to be reverse chronological, but we have to go back 3 years where you have the back pain, 2 years when we have the UTI, the urinary tract infection. And during that time, you have been seen for a lot of other things, and each thing is going to have a different section. So it's going to be a little more troublesome to find the information, to retrieve the information immediately, to file information, because you have to go through all these problems and to find out where the problem was. Do you have this problem before? Oh yeah, like 10 years ago. Well, you have to go 10 years ago and place it on top of that 10 years. And it's today. So it's going to be a little troublesome once again. So this is the problem oriented. In other words, you're not going to be asked all of these. It's just for you to understand how this works. The other one, every single time the patient comes in for anything, that page is going to be placed in front, like reading a book. Page number five. It's like dates. Today is the 18th. Well, the 18th, if you come to see me, is going to be on top. 19, 20, 25. Next month goes on top, on top, on top. The other ones do not go on top, goes depending on the condition that the patient has. You have to go back to that particular condition. And if you don't have the condition, then you open another tab instead of just filing it next to it consecutively. So it's going to be a little troublesome. Now, the medical records is going to be divided in 4 bases. You see, it has more stuff. And it makes it a little more complex, so to speak. It's very complex. So it's going to have these 4 parts, let's say that way. It's going to have a database. It's going to have a problem list. It's going to have a treatment plan, and it's going to have a progress notes. So it's going to have all these sections. The source-oriented, it doesn't have all these sections. It goes straight up. We don't mention the database, problem list, treatment plan. It is, but we don't mention it, and everything goes right on top, next to it. So every event goes after that one, and after that one. It's chronological. The other one is chronological based on the problem. So that's what causes here a problem to understand, to retrieve the information easily. Some of the office, they use it, some others, they don't use it. But remember, source-oriented is the most common paper-based management system. It's like everything else. We have trains, we have buses, which one is faster, which one goes express. Well, it's the same. It's like if we have the bus, oh, well, it has to live with all this traffic. So it's going to take longer. If you take the train, it's going to be faster. So again, whatever makes, this office works better, that's what they're going to use. And the source-oriented usually is the one that works better. It's the one that I use for the time that I was working at the hospital, because it is very commonly used. Again, it's the most common use. So let's talk about the database. What's the database? See, when we are doing the source-oriented, we go straight up chief complaint. All this information is going to be there in both of the methods, but it is the way that you organize them that is different. So the chief complaint, it will be database. So this is, or the database, whatever you're gonna call database is all depends of, it is correct either way. So the chief complaint, what is the chief complaint? The chief complaint is the reason why the patient is looking for medical care. So you need to know this, it's not the database. Forget about the format itself. Think about questions within. So what is the reason that the patient is going to the doctor? What is the reason that the patient is looking for medical assistance? Well, it's called chief complaint. Usually it's just abbreviated CC, chief complaint. So that's one of the things. So when we use the problem-oriented, that's how it goes. We have database, then present illness. Now the patient is going to tell us what conditions they are currently having. Then you're going to have the patient's profile, meaning the patient's information, patient's name, medical record number, phone number, address, the insurance ID, or family, whoever is going to be the emergency contact, the husband's first married, and it's going to have the workplace, who you work for, what do you do for a living. All the stuff is going to be on the patient's profile. Then follows is going to have a review systems. Review systems is like the word explain. We're going to just talk about all the systems in the patient. So usually we ask the patient, are you okay? You have any problems with your eyes? Any problems with your hearing? Any problems with your smelling? Are you eating okay? Are you moving your bowels without problem? You have problems urinating? Things like that. That's review systems. Each one of them cover one system. Do you have any problems with your bowels? Okay, weight wise, are you losing weight or are you gaining weight? So all that falls into one of these systems, because we cover anatomy and physiology for those who cover. So if I ask you, are you moving your bowels normally? That is the digestive system. If I'm telling you, if you are, urinating with no problem, that is the urinary system. Are you having problems walking on? Oh, that is the, once again, orthopedics or the skeletal system, the muscle system, any pains, anything. The nervous system, can you see? Can you see well? Can you hear me? All those things. This is a review, very short, yes or no question. So that's basically what it is. Then we're gonna do a physical exam. So it is more complex now. Because now we're gonna do vital signs. Now we're gonna check your breathing, your heart, and whatever it pertains due to the reason that the patient is there. Remember, the patient is going there because he has problems with their vision. We're gonna focus their vision, the nervous system. If he goes because they have back pain, we're gonna focus on the skeletal system, the muscle system. So that's basically what it is. So this is like all the arrangements, the format that we have to collect information from the patient. And then we're gonna see the lab results. You're gonna see the other one, how easy it is, because that's basically what we need. We don't need to go through every single detail in this fashion. There are a better way to do things, but some people adopted this system and they feel comfortable doing it. Well, they do it and it is correct. It's just that, it's a different system. So that's basically what it is. It's the way that we collect information. Some people collect it in one fashion, or utilizing the first or the second method of collecting
Check
information.
online. So
Hello? Problem list. Now we're going to talk about the problem list. Now it's a numbered entitled list of every problem. Now it's going to be numbered, meaning it's going to be arranged by problems and titles. Oh, it is the nervous system. It is the problem is based on the digestive system, or it is the urinary system, it is the cardiac system, it is the muscular system, whatever the case may be. So it is by problem. It has diabetes. Patient has arthritis. Patients have a headache. Patient cannot pee. Patient has a rash. Patient has a pain of this. Patient has an injury of this, has trauma of this. So that goes by problem. So it's getting a little intense. Now, you do not need to know this, because you only need to know what is problem-based, what is a source-based medical record. That's basically what it is. But we need to explain what it contains within. Why is it that the source-oriented is a lot easier than the problem-oriented? Because the problem-oriented has a lot of things that, we're going to have it with the other one, but it's a lot easier the other one. You will see when we move there. We don't have to go through all these because it's a lot easier to enter information, to collect information from the patient. We just go like straightforward, like we using a shortcut. That is not a shortcut. This is faster. So that's basically what it is. May include social and demographic troubles, as well as medical and surgical notes. Now we're going to talk about everything. Because remember, if it is the problems, it's not what is the problem today, what conditions you have, but have you have surgical procedures from those conditions before? Have you done these particular procedures, surgical or laboratory procedures? So we're going to ask about all that stuff. It's like very redundant, in other words. So we don't want to go through all that. Treatment plan. So during the treatment plan, you're going to go through all these details. It's too detailed, it's too much information that we need to collect at once. In the other one, we are kind of summarizing mostly everything that is there. Why? Because everything that belongs to the patient is in another page, and we don't need to collect that because it's where the patient's history, medical history, where in a page where the patient has medications that is taking, in a page where the patient registers and have all the information. So we don't have to be putting everything kind of together all the time, because that's going to be time consuming. It's going to be too much information. So the treatment plan includes management. Management means how I'm going to treat this particular condition. I'm going to be treating with medications, injections, tablets, pills, syrups, surgical procedure, rehab, whatever the case may be. So again, it is too much of details that we have to write during this, using this particular method of the content of the information inside the medical record. Additional workups needed. Well, that is something else extra that might think that might work for the patient. But in general, once again, when we use the other format, it's going to be just treatment. Whatever the case may be, additional things, we don't just mention them. There's no place there when asked about additional needs. We just add it to it if it was done. If it's not, we don't have to write down none. No, just we don't mention it. But here you have to put something. You can leave it blank. So you have to go over this information. Therapy. Now, if therapy was one, remember, therapy is part of the management. Additional workups are part of the management. It's just meaning that you did something extra. When we talk about therapy, sometimes people say, what type of therapy? People think that is physical therapy. Well, no. Therapy means treatment. Anything that I do to fix a problem from my patient, whether it's medications, whether it's a procedure, whether it's a surgical procedure, an X-ray, CAT scan, that is therapy. When I give something to the patient to make the patient feel better, that is called therapy. So therapy does not mean, oh, physical therapy. No, therapy is a treatment. Therapy means treatment. So that's basically what it is. So if I'm talking about management, I'm talking about therapy. Why? Because I'm using all whatever therapy is out there to make the patient feel better. So that's basically what it is. It's too much information, redundant information, meaning repeating things over and over and over, where I can just go straight forward. Each plan is titled and numbered with respect to the problem. Again, what is management? Okay, I'm going to manage this way. I'm going to add this. There is no need for all that information if I can do it straightforward. I just order a medication. I just order the medication. Oh, I order a procedure. Oh, plus patient has to go to do this procedure. And then we follow up after that. So instead of doing all these workups that it is being done on the other side, but it's not recorded this fashion. It's how we enter the information. That's basically what it is. progress notes. Now, this is what we use for the other one. So within the progress notes, everything is going to be there. So this one has the progress notes, which is what we use for the source oriented, plus all these other add-ons, so to speak. So we don't have to go through all that. Right here with the progress notes, we have all the information from our patients. So we don't have to go through the database, problem list, and management or anything like that, because everything is going to be contained within the progress notes. So here, besides having all these other items, it has the progress notes as well. So it's like repeating things. We're going to write it down here. We're going to write it down here, everywhere. What we're writing is so many parts. So meanwhile, we can do it only in one side. So that's basically what it is. So again, here is the soul. Now, the soul, you need to understand this. You need to know the whole SOAP, the soul node approach or progress notes. You need to know what S stands for. When you need to know what O stands for, A stands for, P stands for. That is the key. This is what we use for the source oriented only. We don't go through all that many, steps just to reach this point. So it's a lot easier when we do the source oriented versus the problem oriented, because the problem oriented has too much details. This one don't have too much details. It's easy to do it and faster, and it has all the information that we need. So again, you must know this acronym, SOAP. We usually call the SOAP node. That's basically it, or progress notes. So you will have questions when they're gonna ask you, okay, so the O on the SOAP node, the progress node, stands for what? O is an objective. Now, what is the S on a SOAP node stands for? What is it? The subjective. Now, I'm going to explain what each word has, what each letter means in reality, because if I said subjective, objective, assessment, plan, probably you didn't understand anything, because you're not going to understand it like that. I have to explain each one of them. It's written over there, but it's very abbreviated, so you're not going to get it. So you need to understand S, because they're not going to say, oh, well, S stands for subjective. Oh, that would be BCK, right? But it's not like that. They're going to tell you, okay, so the patient comes in complaining about back pain. Is this a subjective, objective, assessment, or plan? See, that is the key, because asking you straightforward what S stands for, what O stands for, A stands, that will be easy, but it's not like that. Exams do not ask you that, not directly. Okay, the doctor ordered did the examination of the patient, checked her eyes, his chest and respirations. What part of the soul is that? See, that's a totally different issue. The doctor ordered a medication after, the patient was evaluated and diagnosed with this condition. What part of the soul node is that? So you need to know what it means, not what stands for. Because S stands for subjective, but they're not going to ask you what stands for. Is what is it? What is covered within this part of this acronym? So this is the SOAP node. So S stands for subjective. What is subjective? You need to know what is subjective, what is objective, definition. You need to know in order for you to understand the question. So subjective means that it might be, and it might be real. So, I think that, I have gastritis. because I'm having this as a reflex. But then the doctor says, well, that's what you think, right? That's not a diagnosis. It's what your perceptions, your impressions are about something. So subjective means something that's not real. Let's put it that way. It might be, it might not be. It's something that you cannot see, something that you cannot prove, something that you cannot touch. So this is subjective. If I said that I have a back pain, well, it might be a back pain. Well, it might be something else that you think that is a back pain. I have a headache. Yeah, but there are different types of headaches. There are different types of back pain. Oh, what do you mean back pain? There are different ones. What do you mean headaches are different ones? Yeah, having a headache does not imply that you're sick. Not at all. So it's subjective. Why? Because it might be, might not be. It's an impression. Let me give you an example of subjective. You go to my office and you said, oh, no, I have this headache. I don't know how I'm going to do with it. I've been taking all these medications. It doesn't go away. Okay. So have you had trauma to your head? Have you had this before? Are you having any problems? Have you lost your job? Have you lost a loved one? Oh yeah, I just lost my wife or my husband, and oh my God, I'm being feeling so stressful. And so since that time, start having the headache. Yeah, this headache doesn't go. Well, this headache is not because you're sick. Nothing is wrong with you. This is emotional. This is not trauma. This is not a damage that you have in your brain, and that's why you have in headache now. So do I have to treat your head? No, I have to treat your emotions. I have to treat your psychological problems. Can I bring back the dead? No, we're going to do something else. We're going to receive some therapy. So you see, it is subjective. So headache does not imply that you have a damage in your brain. That is subjective. Subjective. Everything that the patient tells us is considered subjective because it might be, it might not be. I have abdominal pain. Okay, so I have a stomach ache. No, a stomach pain, belly pain. See, people don't know terms, so they said, oh, I have a belly pain. So if I said belly pain, literally, I'm thinking about your navel, your belly button. That's what it means, belly pain. But people, it means something within the abdominal area, within the belly. So that's subjective. It is an impression, it's what the patient thinks it is. And it turns out that it's not the stomach, it's not the belly, it is the intestines, it is the pancreas, it is the liver, it is the kidney. Patient that comes and says, oh, I have a kidney pain. Oh, my large intestine hurts. No, patients do not say that. Patients just what they think they have. That is considered subjective because it's something that you think you have. But when we evaluate you, now we find the objective part. Because objective means evidence. I'm going to do my exam. I'm going to palpate your abdominal area. I'm going to ask you questions. I'm going to do certain evaluations. I'm going to listen to your heart. I'm going to listen to your bowel movement. I'm going to send for a blood test. I'm going to send for urine. Now I have evidence. That is objective. Objective is something that I can see, that I can touch, that I can prove. And who can do that? Medical doctors. The patient just comes with a complaint. Anything that the patient says, remember, that's called subjective. Everything. It doesn't matter what it is. It is subjective because it's the patient who's saying it. It is the impression of the patient. It's what the patient thinks is having. but it may not be. So we have to do those evaluations to prove that it's real, that it's there, but then we have a diagnosis. Just because the patient says, I have a headache. No, it was a headache, but it was not caused by damage of the brain. It was a problem. Lost her job, his job, is having problems in the relation. It was diagnosed with a bad condition. Now, well, it's very stressed out. So we have to find out what is it. So just the fact that you said I have a headache, okay, take these pills. That doesn't work. Because if you have a problem giving you the pills, that's not going to fix it, because we have to fix the problem. Because if we don't fix the problem that you're having that is causing you the headaches, then it will not be solved. So for that reason, we need objective clinical evidence. So the only part on the shift complaint that belongs to the doctor, or to the patient, is S, the subjective. See, patient. What the patient thinks, what the patient assumes, that is subjective. Everything else, you see, medical doctor, everything is medical doctor. Why? Because the doctor is the one who's going to receive your information, your symptoms, is going to put everything together, is going to order tests, and then I'm going to come out with a diagnosis. Now I'm going to tell you, what do you have? So remember, if they tell you, okay, the patient is complaining about this, what part of the subnote is this? Oh, it's the patient that is saying it. Subjective. It doesn't matter what it is. But if the patient is complaining, the patient is mentioning, is subjective. Now, objective. The doctor was doing an examination of the patient that was complaining about, oh, well, the doctor was doing an examination and he found out that the patient has a hernia, the patient has something in their body. They found out that the heart is not beating normally, that is not breathing normally, that saw a rash on the body, has an injury, discovered this or that. Well, that's objective. Objective. The doctor ordered blood tests. Well, I'm ordering blood tests, and when I see the results, that is objective. So this is objective. Now we move to the A, assessment. So what is the assessment? So the assessment means diagnosis. So what is it that the patient, I think, has? As a medical doctor, I put all my evidence together and I said, okay, patient have probably this, one of these things. So now I'm coming out with the diagnosis. We know not always come out with diagnosis, but let's say that the doctor says, oh, you have this. Oh, after the blood result says, your glucose is very elevated, you have diabetes. Oh, I sent for x-rays and you have broken bone. So that's diagnosis. You can complain about anything. Subjective. Objective, all the tests that I'm doing. But now after I send you to do these tests, got the results are objective, but due to those results, I know what you exactly have. The diagnosis is called assessment. So that's basically what it is. Now, what is your plan? Plan is treatment. What is it that I'm gonna do for this patient? See, plan, treatment. What is it that I'm gonna do now to fix the problem of the patient? Does the patient need medications? That the patient needs to do a surgical procedure? Does the patient needs to go to rehab? Does the patient needs what? And all this is objective, but we don't use it as an objective because it's real, but it is a plan. Every single patient has to follow through all of this when it comes to the doctor. We do this subnote all the time. What is the reason that you're here, Mr. Brown? Oh, I have back pain. Okay, we ask all the pertaining questions because we're getting the information from you. That's objective. Did you fall? Do you have any type of trauma? Have you had this before? Have you taken anything to make it better? What type of work you do? Because we need to know that maybe the job that you're doing and you put in certain situations, certain positions, you have to lift heavy stuff, you have to bend, you have to, well, we have to do all the pertaining investigation, evidence, remember. So that's how it works. So you're going to be asked that, okay, the patient is complaining about this. What type of the SOAP note is? Subjective. Remember, if the patient said, it is subjective. The doctor evaluate the patient, examine the patient. What part of the SOAP note is this? Oh, the objective. Patient was diagnosed with diabetes. What part of the SOAP note is this? Oh, that's the assessment. Patient was given this medication, this procedure. It was referred to another specialist to follow up. Oh, that's the plan. Remember, that's the treatment. Remember, medical doctors, not every single medical doctor treats every condition. If I found out that you have a heart condition, I'm going to refer you to the cardiologist. That's my plan. Remember, plan is what I'm going to do after. Do I need treatment? It does need a procedure. Sometimes the procedures, we don't do it. So that is the plan. But sometimes I can give my patient medications. That is my plan and my treatment. So that's how it works. Again, very important for us to understand this because they are going to ask you about this SOAP note and you need to know. So don't get confused about treatments, diagnosis. Most of the time people get confused with subjective, objective, and assessment and plan. So if they talk about diagnosis, you know that this is assessment, period. If you are giving some type of treatment to the patient or have a plan for these patients, oh, I order a surgical procedure. That's a plan. That is going to be a treatment. So you cannot confuse that with objective or with subjective because then, well, it's not right. That's not the way it works. Okay. Any questions about this SOAP acronym, the SOAP note? This is what we use in the progress notes. So progress notes has this SOAP note. So we need to ask all those questions. And the doctor needs to do all these items in order for us to complete the history of the patient every single time the patient comes in. So every single time you go to the doctor, this is what we do. And you remember when you were at the doctor's office, they ask you, okay, so what seems to be happening? Tell me. And for how long it's been going on? Have you had this before? Do you have trauma? Do you have this? Depends on what's going on. And then you're going to be responding to those questions. I'm interviewing you because I'm getting all the facts to make sure that I am going to come out with the proper diagnosis, or I'm going to order the proper test so I can figure it out exactly what you have. Other than that, I cannot give you treatment. So we go through all these steps. This is like an investigation in a case. Okay, what happened? How did that happen? Show me evidence, proofs. And then they're going to decide whether that happened or not, or whether it was guilty or not. So that's basic. And then what is the plan? Oh, we're going to put you in jail, or we're going to charge you, we're going to put you a fine, or we're just going to let you go free. So that's the same thing. So we have to follow all these items in order for us to make sure that the patient receives the best care than the patient is looking for. Okay, so any questions about the SOAP note? Remember, this is very important. You need to know all these letters of this acronym. Remember, they're not gonna ask you what S stands for, what O stands for, what A stands for, what P stands for. No, because that would be easy. Oh, P, plan. A, assessment. Oh, I can memorize that. No, they're gonna give you a little scenario and you're gonna be able to know what is it, if it is part of the S, the O, the A, or the P. That's how it works. So think about it. Remember, the only one that is done by the patient is subjective. Everything else is objective because the doctor is evaluating the patient, ordering tests, is ordering a procedure, giving medication. All this is obvious, is evidence, can be seen, can be everything. So it's very easy to remember that. So chief complaint, remember, is what the patient complains about it. Anything that the patient tell you. Now, it's not that we are not believing the patient. It's probably all those signs and symptoms are there, but it's not that we doubt about them. It's the diagnosis. The patient says abdominal pain, back pain, might not be the back. It might be something else, somewhere else, some other organs that is causing the patient feel this pain on the back, this pain in the head, or whatever else. So when we do all these evaluations, because otherwise, if whatever the patient tell us is true, so the patient is diagnosing themselves. There are different types of headaches. There are tension headaches. There are stress headaches. There are psychological headaches. So there are trauma headaches. There are many types of headaches. So we're not gonna just say, "Oh, I have a headache. Okay, headache. Take Tylenol, Motrin. That's it. Go next." It might be something inside the brain. It might be an aneurysm, a blood clot. So we can't just dismiss the patient just because what they say. No, first we have to go to, to the base of the problem to see what might be happening. And that's what we ask and question the patient. And we use the same question, different wording to see whether, something is really serious going on or not. So that's what we really, really care about. So know the SOAP note, definitely. So here is the SOAP note. Here is part of the progress notes. So if you see right there, it says you can read it. It says subjective, objective, assessment, and plan or treatment. And then additional notes, but these are different forms. But most of the SOAP note just come from there. And you see, here is the body. And we are going to be putting marks in any part that we examine. What is the problem? Oh, the head, the eyes, the arms, the legs, the abdominal area, the back. So we have here the anatomical position. Patient, we see the anterior part, the posterior part, the lateral part, right and left. Why? Because see, the patient is complaining about the left shoulder, the left arm, or the back, the buttocks, the shoulders on the back. So you need to make sure that we mark every single area that the patient is complaining about it. And we write there what the patient is telling us, the questions that we are eliciting to the patient, that we're asking, then we're going to get this information. So that's basically what it is. So again, very simple. Why? Because everything is written there. We just need to fill in the blanks. And how we're going to fill in the blanks? Asking the patient. That's not something that you're going to be doing. You just need to know what the SOAP note stands for. Each of these letters of this acronym, and that is it. You don't have to explain anything else. But I'm telling you a little more so you can be familiar what's going on when you go to the doctor. If they ask you these questions, and sometimes I ask you questions that sounds maybe irrelevant to you, but not to us. Because some of the things is not what you're thinking. Remember, it's not the impression that you have. It might come from something else. So that's basically what it is. So whenever we think that this might be related, might be due to something else, then we're going to ask those pertaining questions. Even though if they do not sound relevant to you. Because remember, we are the medical professionals and we ask questions for some reason. So don't think that the doctor doesn't know what they're doing. It's just that this is the approach that we give. Remember, doctor is like a detective. Detectives in the real life, in the law part of the story, are looking for clues of who did commit the crime. Or what is the missing person? The medical doctor is trying to figure it out. What's wrong with you? What is the condition? So we can treat you fast and accurately. So that's basically what it is. Any questions about the soul? Remember, you can see it. Here we have another acronym. So I want you to be familiar with this just as much as you were with the SOAP note. Why? Because you're gonna have questions from here too. Here, they're just gonna ask you exactly the opposite of the SOAP note. Here, they're gonna ask you what the C stands for. This is the Cheddar acronym. They're gonna ask you what the C stands for, what the H stands for, what the E, the D, and the AR stands for. So that's basically what it is. They're not gonna ask you every single letter. No, they're gonna pick one. So they can ask you what is the A on the Cheddar acronym stands for. So then you're gonna say assessment. So very similar to the SOAP node because SOAP, SOAP, stands for assessment. What about the D? Remember, you have two Ds. And because you have two Ds, be careful. This might be the question that you will be asked. What is the D on the acronym Cheddar stands for? Then you're not gonna see drugs or dosage, but you're gonna see details, problems and complaints, but D for details. So again, just get familiar with this acronym because I heard them, they use this for the exam. So be familiar. Just keep it in mind. Because remember, this is going to be easy because only you're going to be asked about what each of these letters of the acronym stands for. Remember, you have to read the question because sometimes, see, we do not read the questions. Let's rephrase it. It's not that we don't read the question. We read the questions. We don't interpret the questions. We just read it like, oh, well, I know how to read. Chief complaint, reasons for the visit, but I don't even understand what is the reason of the visit mean or what is the chief complaint actually means. Again, you need to focus and read the question deeper. It's not just reading it, it's understanding it. So if you don't understand, you can get the wrong answer. And you know that better than I do right now. When you take your test, you assume that this is what it is. And it turns out that it wasn't. Because we don't read it. We actually don't understand it. We don't comprehend the meaning of the question. We assume that it is. We kind of go superficially And that's a huge mistake because that's when we make mistakes. That's when and once again, I cannot stress enough. We put our own experiences about something and we use that experience to answer the questions. That's what we've been doing all the time. Oh, what is this? Oh, well, I heard this, I saw, oh, I think that I went through that, so I'm going to put that. Now, think about this. If it was something that I didn't cover during the test, I didn't mention that word, why are you going to be using that as an answer? If I never mention it, no, there are some words that I use repeatedly, constantly. So, and I repeat it and I repeat it and I repeat it. Those are words that I didn't repeat. It shouldn't be considered. That goes for every single exam in every single situation. If I never say it, I never repeat that, well, that's not the answer, period. We're going to use different terms that are similar to that, but it doesn't imply the same. So we got to kind of make sure that we get this down, because it's very important that you understand how all this goes. So for this one will be what each letter stands for. Now, when you read the question, they're going to tell you, okay, what HIPAA stands for. So when they ask you what HIPAA stands for, you're going to say, oh, H is Health Insurance Portability and Accountability Act. So each letter stands for something. Now, it's not the same if I ask you, what is HIPAA? What is HIPAA? It's not the same as what HIPAA stands for. When I ask you, or you hear the question, what stands for, is which one of these letters stands for. But if I said, what is HIPAA? Oh, that has to do with privacy, confidentiality, and security of the patient's history, the patient's information. That's what is HIPAA. Not Health Information Portability and Accountability Act. That's not what it is. So we need to understand the type of questions, because we go there 100% sure, oh, that's Health Insurance Portability and Accountability Act. And then we got it wrong. And it says, oh, wow, no, my question was right. No, wait a minute. Did you read the question? It says, what is HIPAA? What the HIPAA does. Not what HIPAA stands for. What SHRR stands for. What SOAP stands for. We're not asking that. So you need to understand the type of questions and what is it exactly that they asking. Otherwise, we're going to make mistakes. And we don't want to make those mistakes, believe me. In an exam, you don't want to. So you want to get all this straight. It's just understanding the question. Okay. Any questions about SOAP or the SHRR acronym? Remember, I don't know exactly each question you're going to get. I haven't taken the test myself. But when my students take the test, says, oh, I got this, and I got this, and I got this, oh, I learned from that. And then I share it with you. Subjective information. See, right here, we have definitions. Subjective information, or often called symptoms, are statements from the patient's viewpoint. See, every single time that the patient said something in the office about the medical condition is subjective. This is like when someone hears about some rumors, some gossips. It might be true, it might not be true. So don't take it as word. Don't take it as if it was true. So those are symptoms. That's what the patient perceives, assumes that they had. But when then I started doing my physical exam and asking questions and doing the results, then I'm going to find something totally different of what the perception of the patients or viewpoints are. So that's basically what it is. So that is subjective. Remember, it's very important to understand this because every single time that the patient comes in, they tell us about symptoms. Symptoms are considered subjective, always. It doesn't matter who's complaining about the symptoms, but symptoms are subjective. Signs, on the other hand, are objective. The patient says, oh, I fell. Well, that is subjective. What do you mean it fell? It might be fell, somebody might throw you out. I don't know. But then I do see that you have a bruise, you have broken skin or broken bone. So then, oh, wait a minute, I see it. I can touch it, I can see it. That's obvious, that's objective. I see the results, the broken bone right there. I send for an x-rays. Now, I have a trauma. I fell, I have a pain in my leg. But what's causing you the pain? The trauma, but you have a broken bone. Or you don't. That is subjective. People comes to our office all the time, particularly in emergency. Oh, I have broken bones because I know I have them. I fall, somebody hit me with this. And then you're gonna do x-rays, there's nothing there. There's no broken bones, but the patient assumes that it was a broken bone because of the type of trauma they have. Or just the assumptions that they have. So the symptoms are subjective. So we have to learn all this. Once again, when you talk to your patients and you ask them, oh, what's the reason of your visit today? And they tell you something, those are the symptoms. Do not challenge the patient. Do not judge the patient. It is what it is. Whoever needs to decide whether the patient is telling the truth or have something or not is going to be the doctor. We just there taking information, next, and next. That's basically, we're not going to get tangled in any arguments or discussions with patients or taking the whole history. No, it's just what is relevant for us. Everything else, we don't have. So content of the complete case history, subjective information. Look what is considered subjective, and you will see that all this is what the patient tells us. Patient's full name. How do we know that this is the real patient's name? Well, probably not. So again, it is subjective because this is information that we're getting from the patient. We're not gonna do investigation, birth certificate, DNA test to figure out if it is. No, it is what the patient said. What is your name? Oh, my name is Alberto. What is your last name? Oh, Hoya. Well, you have to take my word for now. That is subjective. Parents' names. If, well, you're a child, of course, at that moment, because you're a minor, so you need to come with a companion, with an adult person. Gender. Hey, you can say anything you want. So again, everything that the patient says is considered subjective. Oh, but I see that it's a male, it's a female, it's this. It's not that. It's what the patient is saying. It might not be. It might look like a female, but it's not. It might look like a male, but probably it's not. Day of birth, whatever the patient says is considered subjective. It might be your day of birth. It might not. I know many people that don't tell the day of birth, lie about it. So it's subjective. Marital status, whether it's married, whether it's single, whether it's widow, whether it's divorce, is what you say. So again, subjective. Spouse name, okay. Her name is Louise, her name is Sandra, her name is Mary. It doesn't matter. is what the patient is saying, subjective. Number of children, you can say that you have 100 children, maybe one, maybe none. Maybe you do, maybe you say no. Who knows? Subjective is what the patient is responding to. Now, when you prove and you have all the evidence and things, well, then that will be objective. For now, everything the patient is asked and respond is considered subjective, period. So social security number, your address, telephone number, all those things. Now, I'm not saying that your social security is not yours. No. It's like it might not be yours. You might have a social security, maybe you may not. I have lots of patients in the emergency that have a fake driver license that was using somebody else's security number and insurance numbers and different names because it has to match with the insurance. Hello. So does not imply, once again, that is objective. It is subjective because it's what the patient is responding to it. It might be true, it might not be. So this is not a question that, I'm going to doubt, I'm going to judge my patients every single, no, but because the patient is saying it until proven otherwise, it is objective. Period. Is that the way it is? And that goes in any situations. Whatever somebody's saying is subjective. In the medical, that's how we take it. Any questions about what is subjective? Here more. See, I mentioned already. Email, any personal information, the patient's profile, occupation. What do you do for a living? What is your work? Where do you work at? What is your boss name? What is your boss address? Your company address? Your healthcare insurance. Remember, I mentioned this already. So again, all this is subjective. It might not be. So, because I cannot prove it, we just take your word for it. But then we do the due diligence in the medical and we're going to start working out, not trying to figure it out if that's your email address. No, that's not our business. Medical speaking is just based on the CHIP complaint. Any other information is up to you. But again, very important that we differentiate, what the patient says versus what the medical doctor finds. So that is the big difference. Personal and medical history. First, we start with the patient, the subjective part, which is all the patient's info, the patient's demographics. Remember, patient demographics is all the patient's information. It's like the patient's profile. Our profile is our demographics. It's going to say our name, date of birth, where we live, any contact numbers, emails, social media platforms that we have, all those things. That is patient's information, the profile, the demographics. That's what we call. Now, this is personal medical history. It's the patient's medical history. So that's basically what we're going to do. We're going to ask everything is related to the patient, not to the family, because we're going to have family history. Then we're going to go to social history, but this is related to the patient. Because it's very important to understand what entails each one of these, what is included within the patient's history, within the patient's personal medical history. Just as we did previously with the patient's information. We need to have all the information that can reach the patient, that can identify the patient. Here is the medical part. Often obtained by patient's questionnaire. So we're going to give you a questionnaire And we're going to ask you, well, if you have any of the following conditions, any of the following procedures, everything related to the patient. Are you taking any medication? Do you have any allergies? All those things are going to be related to the patient. Do you have, or do you still have something? Because sometimes you have conditions that you had it in the past, but you don't have it now. So that's basically it. So we need to know everything about our patients. Provides information about any past illness or surgical procedures, operations. Again, we're going to ask everything, whatever is possible. Why? Because it's very important for us if you have a past medical history or disease. Illness means disease. Yeah, I used to have, tuberculosis, but it was treated because it's something that is treatable. But this can be something that, is going to affect other conditions, other organs in your body. So we need to know if you had it in the past. Or if you have these in the past, but you still have chronic conditions, diabetes. Oh, I suffer of this type of cancer, but I was treated, so you no longer have the cancer. See? So there are conditions that in the past you have them, but now you have history. So that means that you can be prone, you can be at risk of developing that condition again, or that condition left sequelas, left something behind that now is coming back. So we know how it works. Explain injuries, physical defects, anything that you have, we need to know it. Oh yeah, like a long time ago, I have a car accident. I broke my shoulder, I broke my femur, I broke any bone of my body. I was hospitalized. You'd have to tell me what hospital you were, for how long you were, what procedures they did over there, whatever you still remember. So we need to know, because that's going to help us to determine other conditions that you might develop later on related to those traumas, to those conditions. The more conditions that you have, the more prone that you have to get more conditions, because you already have a problem. You already have some kind of weakness inside your body, because all the conditions. So you are prone to develop other conditions a lot easier from someone who do not have these conditions. That's why we call patients who have all these conditions that, they are developing other things very easily. Those are called pre-existing conditions. When we get to insurance, we're going to talk about that, pre-existing conditions, because our conditions that are already there before you join this medical insurance. But for us in the medical field, we need to know, because that can be related to something that you are developing now, some conditions. The other one is to see how much they're going to charge you for the insurance, because you already have something, versus someone who do not have medical conditions, because you are more at risk of developing something, spending more money, so I have to charge you more. I'm talking about the insurance. So again, it's very important from any point of view, whether financial or medical. Information about the patient's daily health habits. See, when we talk about habits, we're talking about the food that the patient eats. Because that's important, whether the patient do exercise or not. What the patient, that will be part of the social history as well. But again, it affects the patient's well-being. You're not eating properly, or you eating things that you're not supposed to be eating, it's not healthy enough. So again, we need to know a lot of stuff because that can lead us to determine diagnosis or procedures, treatments. One of the first things that we ask after we ask the patient for the chief complaint or the reason why the patient is in the office looking for medical care is always we're gonna ask about the patient, see the patient is allergic. Now, if the patient have allergies, you can see, let me rephrase this. Most of the times, if you're gonna ask the patient, and probably you've been in that situation when they ask, oh, do you have any allergies? Oh, yeah, I have allergies. But they didn't tell you what type of allergies. Do you have medication allergies? Have you presented with any allergies to medication that you have been taking? Because allergies is like a general statement. So you have to ask, oh yeah, I have an allergy, but you don't ask about what? What type of allergy? Oh, I have food allergy. Oh, that's different. What type of food? We need to know in the medical. Because other than that, can you imagine there are some medications that are derived from maybe that type of food that you're eating, and that's going to cause you an allergy. So again, one of the ingredients from these medications might be from a plant, might be from a mineral, might be from an animal that is causing you that. Now it's going to be in the medication. So we have to ask whether you are allergic to medications, food, to environmental allergies, like pollen, like grass. All these changes of seasons here in this country make you develop allergies. Actually, I developed those allergies myself. I have allergies to fruits as well, but it's not the fruit itself because I'm used to eat apples, pears, apricots, all these berries. Now I have a problem eating them here. But you know what it is? The chemicals that they use, the pesticides. Because when I go to my country and I eat the fruits that I'm used to eating, and they are just, well, they call it organic, but it's because they don't use all these chemicals, all these pesticides. And I eat them and I have no problem. I love berries, I love strawberries, I love apricots, I love apples, I love grapes, but I'm allergic to it here. I go over there, I'm afraid to eat it. But when I eat it, because I see it, I said, no, I just wanna eat a little bit. I just wanna take a bite. And I do it, and then I realize that I didn't get these allergies. I keep on eating over there. But here, I refrain myself from doing it. So you actually need to ask. Now, if the patient tell you, oh no, I don't have allergies, you have to write it down. But you have to write down what is it that you don't have. No known drug allergies, if that's what you ask, or just no known allergies, no known food allergies. Don't just write down, oh, no allergies. No, because the patient might have allergies to food, might have allergies to medication, might have allergies to the environment. So we need to actually write down and explain to the patient what allergies are we talking about. Remember, patients do not know this. Do you have any allergies? Oh, no. Not that I'm aware of. Patient denies allergies to medication, denies or non-known allergies to medications, to drugs, to environmental. That's what we have to write down. And that's the right way of asking questions. So that's basically what it is. Another thing that you have to ask is if they have any advanced directives. Remember, we talk about advanced directives, which is orders that you leave to treat you in case, to give you medical treatment in case that you cannot make decisions for yourself, like a living will, like DNR, like the health proxy, or the durable power attorney, or do not resuscitate. See, we have to know what's going on because they might have one. And it's important for us to know whether they have these documents on file or not. And that's another thing. You have it and you have it at home. So then you can mention it to the doctor and the doctor can ask the patient to bring it so we can keep it in our files. Because if the patient have it at home, it's no good. Because if something happens to the patient, the first thing that they're gonna be brought to the hospital, to the emergency, they're gonna contact the medical doctor, but the medical doctor don't have this on file. So then a waste, we're not doing anything. So again, there are certain things that we need to kind of, be aware of and ask correct questions to the patient. Because if you don't ask the pertaining questions and the appropriate questions, so to speak, then no, not good. The history is not collected appropriately. So that's basically what it is. So this is the personal medical information format. So it's gonna ask a lot of stuff. It's gonna have all the information of the patient, again, all the medical profile, all the personal profile. Then we're gonna ask about questions. We're not gonna ask, we're gonna ask the patient to fill this, to complete it. Now it's a lot easier because remember how the patient is gonna know if they have any type of cancers. And sometimes they don't know how to write it down. So if they don't know how to write it down, then they do not add it to it. If you leave like the blanks, any medical conditions, okay, blank, 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 blank. No, here it is written. So you're just gonna check, 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 check. If it meets the criteria, if you have that, you just place a mark over there. Remember, this is the patient's personal medical history. Patient's medical history. This is not the family. So we're gonna have a format for the family history. For social history, which we discuss tomorrow when we continue with this chapter. Any questions? So you can just scan over, look at it. You have it in your PowerPoint presentations, your PDF formats, and you just can see it, and you're gonna be, getting informed about what exactly it contains within. Because when you go to the doctor, the first time that you register, usually this is what they gave us, this paper, so we can, mark, and we have to be very honest. If we have something or we had something in the past, we have to write it down, because then the doctor is going to have an idea of what things you have had, what things you had or you did not have, so they know how to go around a diagnosis. That helps a lot. If you omit some of this information and you're having a problem, and I see that you are too young to develop that condition, I might think something else. But if I know that you have a history of this, then I might say, hey, or you have a family history of this, I might say, wait a minute, this patient might be in this particular situation. So we're gonna order certain exams, certain tests, certain laboratory tests or procedures